That's what I was looking for. Dr. Klafter, his name is recognizable to all who are associated with Enmeshed. Dr. Klafter is a psychoanalyst and psychiatrist specializing in the treatment of adolescents and adults with complex psychological disorders, including severe personality disorders, refractory mood disorders, relationship problems, and post-traumatic syndromes. He directs the Advanced Psychodynamic Psychotherapy Training Program and oversees the technique curriculum at the Cincinnati Psychoanalytic Training Institute. Dr. Klafter has published and delivered professional trainings and workshops regionally, nationally, and internationally on the theory and technique of psychoanalytic psychotherapy, self-disclosure, boundaries, ethics, transference and countertransference, personality disorders, and various aspects of the interface between Judaism, mental health, and psychotherapy. In his private life, he is married and the proud father of 4 girls. He lives in Cincinnati, Ohio. There may be other elements of his private life that he's willing to share with us, maybe other elements that he's unwilling to share with us. We may never know. But without any further ado, the man who's been introduced but who needs no introduction, Dr. Klafter.
Thank you. Let's just clarify a few things. Since it's on boundaries, we'll try to be clear at the beginning. What time are we going until? 5:40. Okay. Right. So we'll try to stop on time. So let's plan a 10-minute break at, what's halfway between those? I was told there wouldn't be math. It sounds like that's about 3:20. Okay, so we'll stop at 3:50 and start at 4. Okay, I got it fixed. Thanks. So the way I like to do presentations is to have people interrupt with questions as we're going along. Do it by raising your hand. I'll be responsible to make sure we get through all the material, but we can do that rather than leave questions to the end. So I was going to tell you who I am, but David did such a good job, I think we can skip this page. So let me just give an overview of the key concepts that we'll be discussing today. So we're going to discuss professionalism. We're going to discuss professional behavior and unprofessional behavior. The idea of fiduciary duty, dual relationships. These are all aspects of professionalism. We'll discuss what boundaries are, what boundaries mean. We'll discuss the concept of a frame. Now, those of you who have like a traditional psychotherapy education and are familiar with the terms boundaries and frame, I promise it won't just be review. I'll be talking about those in a new way. And those who haven't heard of these concepts before, they're very helpful concepts. We're going to talk about boundaries as clinical technique rather than ethics. Often boundaries are part of a topic in ethics, but I'm not really, I will mention a little bit about ethics, but this is not about ethics, this is about clinical technique. Boundaries are a very important clinical technique, and that's the aspect that we're describing today, not ethics. We're going to talk about the concept of small world issues. I don't know how many people just in the few minutes before here figured out that they know people in common with me. We're all in a very, very small world. In fact, we have a ritual. We play Jewish geography as soon as we meet people, and we clarify how small our world is with one another. We're going to talk about dealing with who I call helpful others. And who are helpful others? They are Rabbanim, Askanim, Rebbitzins, certified Jewish mental health yentas. That is a term that I learned from a colleague of mine. How to deal with helpful others in our practice in this very small world. What should be on that list is the concept of enmeshment. So I'll start with the idea of boundaries and frame. Okay. Actually, we're going to start with the idea of professionalism is what we're going to start with. So here we go, professionalism. Okay, so professionalism, in its basic definition, is providing a service for which you're qualified based on your training and expertise. That's what it is when you're a professional. That may be if you're an auto mechanic, if you're tuning pianos. You have expertise and knowledge and training that qualifies you to provide a service that a person can't do for themselves. That's what it means to be a professional. Implied in that is acting in your client's best interests. You know, if you're a professional and your client doesn't have the knowledge that's required to provide that service, there's a power differential. And in order to not take advantage of the power and knowledge that you have, and the client for your services doesn't really have the same tools to evaluate whether you're doing a good job or not, you're called upon, it's just sort of natural law, natural ethics, that you have to act in your client's best interests. That's part of being a professional. Fiduciary duty is a special type of obligation. It's when you are paid and hired with an explicit understanding that your duty is to look out for your client's best interests. So what are examples of professions or professional roles where you have fiduciary duty? In other words, one of the things you're being paid for is not just your expertise and your knowledge, but that you are going to act in your client's best interests. What are examples of that other than psychotherapy? Psychotherapy and being a physician, those are examples where you have an explicit fiduciary duty. It's part of your license agreement. What else? Yes, your investment banker, your lawyer. These are roles. In fact, where you've probably seen the term fiduciary most often is when you have an agreement with your bank. They use the term fiduciary. So a lot of people think it's about money. It's not. It's about acting in your best interests. In halacha, that should say apitropis. It's misspelled. The idea of an apitropis is like a guardian, like a professional guardian appointed by the community to look after someone's best interests, usually orphans, children who don't have parents look after their best interests. The court will provide someone to look after their best interests. Now, there's a verse in the book of Deuteronomy that's going to be important for us. Lo satem mishpat, lo takir panim, v'lo tikach shochad, ki hashochad ye'ver einei chachamim, v'yisalef divrei tzadikim, which means do not show favoritism in a legal proceeding, and do not accept bribery, because bribery blinds the eyes of the wise and perverts the words of the righteous. So this is a mitzvah that is really for judges. When judges are adjudicating a case, they have a duty to avoid any type of gift or favor or inducement. There are stories in the Talmud about the lengths to which the sages would go to avoid being bribed, but they have a duty to be impartial, and bribery is considered something that interferes with their impartiality. Now, why am I telling you that? I'm going to reveal to you a personal psak that I received once. I'm not saying this is the halacha or recommending anything, and I'm not a rabbi, but this is instruction that I got from a rabbi. It's just interesting idea. So I was told that I'm not allowed to receive even pens or notepads with the names of drugs on them from pharmaceutical companies. Why am I not allowed to? Because according to that rabbi, his opinion is professionals who are expected to serve as fiduciaries, they have the same halachic duties as judges as far as avoiding bribery. So if you're, and now I don't think every rabbi agrees with him, but it's just a very interesting idea. You're called upon to provide the best services you can to the best of your ability in your client's best interests. So what are things that interfere with your ability to do that? So this is this rabbi's opinion. I thought it was just an interesting concept. It's not like being a business associate or a partner. You know, if you're doing a real estate deal and you're selling real estate to someone else, you do not have a duty to act in that person's best interests. Now, you're not allowed to commit fraud. You have to disclose defects in the property you're selling, but you are not required to act in their best interests. You're acting in your own best interests. You're going to get the best price you possibly can. You can't be dishonest, but you can negotiate to the best of your abilities to get the best fee. That's totally different from being someone's fiduciary. If you're someone's fiduciary, you're acting as their agent. You have to work I assume a real estate agent is also fiduciary, by the way. They don't seem to act like fiduciaries. I don't think they have lectures like this at their conferences. I shouldn't say that, but I don't know. It doesn't look that way. But, you know, that's part of being a professional, and being a professional therapist. We are fiduciaries. We've signed up to act in our client's best interest. That's like part of the deal, in addition to the expertise we provide as therapists. So professional behavior is behavior conducting oneself in a manner that reflects the following: your intention to provide professional services to the best of your abilities and commitment to your patient's best interests. That's what professional behavior is. Like, you are enacting in your concrete behavior those values. Now, what's unprofessional behavior? It's the opposite. It indicates that you're not really trying to provide the best services you're capable of, and it conveys a lack of commitment to your patient's best interests. So what are things that are professional or unprofessional? I think your attire, the cleanliness of your office, listening carefully, taking notes, showing up on time. These are all things that reflect your commitment to acting like a professional. So the opposite of those things indicates otherwise. I mean, if you're eating while you're talking to someone, if you're looking at your phone and texting to someone while you talk to them, if you are distracted routinely all the time, none of us are perfect, but, you know, if you go out of your way to try as hard as you can to set yourself up for success as a therapist, that you are in your best frame of mind, you're listening as carefully as you can, that is what it means to be a professional. You're really doing your best and conveying it, that that's what your intentions are. And one of the things that I want to clarify is that professional behavior does not just affect your patient's confidence that you're acting in their best interest and doing your best. It actually affects you. When you are acting as a professional, when you show up on time, when your space is decluttered, when you are doing the best you can as a professional, you will perform more effectively and better. When you're eating, when you're not at your best in that way, your work also won't be at its best. It's not just a show. It actually affects your performance in that way. So when we talk about boundaries in the frame, we're talking to some degree about a way of conducting yourself that puts you in the best possible frame of mind, emotional position, and place of comfort to act like a professional. That's part of what your boundaries do for you. Dual relationships is another important idea. Dual relationships, to explain what this is, so to back up, professionals provide services to their patients, and they expect nothing in return from their patients other than the fee for their professional services. That's all you get back, okay? Your patient's job is not to take care of you in any way other than to pay you, okay? Now, I would say that they have to show up on time, but they have to pay me whether they show up on time or not, okay? I mean, if they continue to not show up on time, there's a question as to whether treatment is happening, and you may have to terminate. But really, all you get from them is your fee. They don't have a duty to take care of you. They don't do favors for you. And so a dual relationship, okay, let me back up again. So that's totally different from friends, lovers, rabbi, congregant, teacher, student, neighbors, parent, child, siblings. All these relationships are reciprocal relationships. We have needs from our students, needs from our friends, needs from our lovers, needs from our neighbors. We expect now, parent-child is not a reciprocal, symmetrical relationship, but it is a two-way relationship. Parents have needs from their children, and neighbors have needs from one another. And your ability to function in that relationship is kind of predicated on the other person's ability to enact that role. Being a friend is so different from being a therapist. There are people that you could function very well for as a therapist, but you wouldn't do very well for as a friend. Because what you need from a friend, or what you provide friends, it doesn't work for one another. But it might work very well as therapist-patient. It's a totally different kind of role. And what's really different about it is that you need nothing from them. There's a huge power differential in therapy. Now, why is that? Because the patient is called upon to become vulnerable And the patient needs the therapist to maintain safety and protection. That's part of how it works. I'm asking you to open yourself up to share with me the things that are the most delicate, the most personal, the most vulnerable, the things you're most scared of. You're giving me a tremendous, level of access to the things that bother you the most, that rattle you the most, that frighten you the most. And there's a real vulnerability that happens during therapy, and I'm not doing that in reverse. I'm not making those parts of myself open and vulnerable. Now, it's true that in order to function effectively as a therapist, I have to be in touch with those parts myself, and I have to have a command of them during the therapy because I'll be triggered during the therapy. But that's different than making it vulnerable and available to the patient. You're not doing that. That's like a private matter for you as a therapist that you're managing, mostly internally. So it's very easy to exploit this differential. Patients, when they've opened themselves up to you, they really need you very badly. You could harm them very easily. They need you to continue with them. They need you to be available for them. They would do many, many things that are against their own best interests in order to not lose that connection because they're so vulnerable to you. Therapists often do not recognize the profound vulnerability. And I'm saying that not from a pedestal of more knowledge than you. I'm part of that also. It's really, we all fail to recognize just how deeply vulnerable our patients make themselves to us and how desperate they would be to preserve the relationship if it were threatened. And we just are not really in touch with that very easily. One way to be in touch with that is to become a patient, but I still don't think that we're always that in touch with it. I think that it takes just an enormous level of attention to really consider how vulnerable our patients make themselves to us. And therapists are typically not aware of it. And when we hurt clients, when things don't go well and we hurt our clients, we usually are just not aware of how delicate and sensitive they are because of how vulnerable they've made to us. That's probably the most common therapeutic error and the reason that most therapies, when they fall apart, that they probably do. Yes, go ahead. Okay, so I'm going to repeat questions for the recording and in case people don't hear in the back. So the question is, when a therapist has failed to recognize the patient's vulnerability and they've hurt the patient in that way, how is it repaired? So this, this is a very involved topic. I'd say in general, it would be becoming aware that you've hurt the patient in that way, becoming aware that you were unaware of how sensitive they were and what you did to avoid that sensitivity, and acknowledging it verbally, apologizing for it, committing to try to never do that again, and inviting the patient when you move forward to be more open with you if they can be about when they feel that you're stepping on their toes or neglecting them. And, I think as we have a saying in Judaism, dvarim hayotzim min halev nichnasim b'lev, that things that are expressed sincerely are usually accepted. So I think that that's really generally speaking, that's the way to do it. Now, there are patients, this isn't what I intended to lecture about today, but there are patients who, sadomasochistic patients, use their victimhood as a weapon against you. So there are some patients who are very adept at getting hurt by you and then use that to sort of dominate you, and that's what they're doing in their lives. These are usually people who have been traumatized and are angry, and their lives are a pattern of being hurt by another person and getting very mad at them. So that's going to happen in the therapy also if it's effective therapy. And so you also just need really good clinical insight into what's going on with the patient to handle that therapeutically. That's a question of your formulation of the case and your therapeutic skill. So sometimes that's part of it also, is that you need to use this opportunity where the patient is getting angry again at another person, sabotaging a relationship, getting power over you by being victimized. But that's a subset. But in general, the model would be that you own it. You own it and you apologize. And patients are, I'll put it this way. I have gotten very good at apologizing over the course of my career. I'm really, really good at apologizing when I hurt people. Patients will ultimately be very exploited if they develop friendships, business partnerships with their therapists. If they take on, let's say you have a patient who's an accountant, and you really trust your patient, and you hire them as an accountant for services, and maybe it even helps them financially, they're going to be exploited by you. It's just, they can't be professionals and protect their own needs and charge you properly or charge you extra when you take up extra time. They're going to be exploited if you make the relationship a dual relationship, because in the dual relationship, they will do more for you than they would ordinarily do because of your role as the therapist. So this idea of a dual relationship is dangerous for the patient's welfare. Now, what is unethical? It's considered unethical to hire your patient, to go out to lunch as friends with your patient, if you start to develop a relationship with your patient that is not the therapy relationship, like you guys shop together and you also do therapy together, that's considered unethical. The different licensing boards have included like explicit things that are not allowed. But that's, when the professional consensus has developed a sense, whenever this happens, that's going to be unethical. People are hurt. You have to use your personal sense also. Like, am I getting into a situation where, my patient and I keep asking my patient to give me recipes, good recipes, or I'm asking my patient for shopping advice. We do kibitz with our patients a little bit, and I learn lots of stuff from my patients about the world. But you need to just always stay attuned to whether that relationship is becoming something other than a therapist-client relationship. And I'm not just talking about like a slippery slope to sexual boundary violations. I'm talking just that extra dimension to the relationship itself will become exploitive, because patients will do things for you that are against their best interests. So you have to really be judicious about not doing that. So professional boundaries are, this is my definition, the limits and rules that psychotherapists place on their behavior in order to preserve and protect the professional relationship. Okay? The boundaries are your role. That's what boundaries are. It's a role. It's how you stay in a professional-only role. Now, that doesn't mean that you can't be warm, that you can't tell a joke, that you can't make a condolence call. It doesn't mean that you become like a cold person. It means that you don't demand from your patient anything other than the professional fee. And you stay in that role. You do your best to monitor that role. Your boundaries are your ability to stay only a professional. That's what boundaries are. There are rules-based approaches to boundaries. Okay, now what do I mean by rules-based? No gifts, or probably most of us will be willing to accept a small gift, but some people won't accept any gifts. Now, there are times, I actually respect the rule of no gifts whatsoever. When your patient has, let's say your patient suddenly comes in with a small gift for you, and it's not something that they ordinarily do. You should wonder, why is he giving me a gift? I think frequently, I'm not saying this is the only reason, but this is like a common reason that comes to mind as I think about this. He's worried that he said something mean to you, or he's worried that he hurt your feelings, or he's worried that you're getting frustrated with him. And the gift is sort of a peace offering. That's what many gifts are. They're expressions of intent or affection in some way. And why is it important right now for the patient to do that to you? So if you accept the gift, you might be bribed. It's an example of bribery, actually, getting a gift. you might be smoothing over a situation, you're colluding and smoothing over a situation that requires therapeutic processing. So let me think of an example. It's not hard to think of examples where patients are mad at me for something. I had a situation where I did not remember. What happened was I have a few patients where, just by coincidence, like two women where one of them, I'm going to not use the real names, but the husband is David and the son is Yosef. And the other one, the husband is Yosef, the son is David. And it's just like and also it's not names like that. It's like really goyish names that I barely know in the first place. So I have this like jumbled thing, and I can make the mistake and refer to the husband by the son's name or vice versa, and it makes the patient annoyed with me. Okay, so the patient kind of snapped at me like, "Can't you get my husband straight? Don't you listen to me?" You know, and like I hurt her feelings. She felt really badly about having snapped at me. She was worried that she had hurt me. And so let's say that she would come in with a gift. I baked cookies, and I thought you'd really like this cookie. I'm giving them out to people. I want to give you this cookie also. So I have a duty to be her therapist, and I have to wonder with her. And I think that the gift is like a marker for, why is she giving this gift? And I will think back to the last session. I'll remember she got mad at me, and she did kind of scold me, and it was like harsh what she said to me. So that did happen. So it is more important to process with her that she was mad at me and she lashed out at me, and now she feels bad about lashing out at me. Like, those are the emotions she's coping with. Accepting the gift actually is counter-therapeutic. It does away with those emotions. That's the reason that there were rules for no gifts. Now, the rules have changed to no gifts over a certain amount of money. Like, I just had to, in order to get my faculty appointment reinstated at the university, I had to study the new ethical rules. So I think that you're not allowed to accept gifts that total over like $10 per gift and $25 or $50 per year from any pay. This is for all physicians in the university. Now, that's about something else. That's not about therapy technique. But people that, in terms of therapy technique, it was about never accepting a gift because you're overlooking a therapeutic issue. You're overlooking an emotional thing. Yes? Okay, so look, I think that there are times when if you need to use your clinical judgment. If you think that the gift is not really meaningful, that this is what someone does. Like, I have a patient who, for a month before Christmas, she's an artist. She designs a new holiday card, and this is like a big thing that she does for the entire year, and she designs them. She's an artist. She gets them printed, and then she bakes like some kind of like a honey cake that goes along with them, and she gives them out to hundreds of people. That's what she does. And sometimes she has a photograph of her family with like an update on what's happening in everyone's lives. So if she gives me one of those, I think it would be, just foolish to think that it's about the prior session. Now, I don't think there's anything wrong with me saying, listen, I really appreciate the thought, but I have a policy to never accept gifts. I don't think there's anything wrong with me saying that, and I don't think that's going to hurt someone's feelings. I also think, it depends on the kind of practice you have. If you don't practice that way, that you spend a lot of attention to what people's behaviors are with you, then it might just sound weird. It's so you've got to use your clinical judgment. But if you accept some gifts and then you don't accept others, you're going to sort of be in a position where now you have to explain why you're not accepting this gift. So you really be called upon to explain why you think this gift is significant. And then it's like, so it really depends. It's sort of a messy area. There's no right or wrong technique. What it is just you have to be able to process the emotional meaning of your patient's behavior. You don't know exactly what it means. You have tools to inquire and sort of figure it out together. But by thinking carefully about all these kinds of little boundary issues, it gives you another tool that you wouldn't have otherwise if you have the ability to think about it. Yes?
If I may ask two questions. One is regarding giving receiving this on the client. I feel like a lot of our work with clients is about oftentimes making them less centered, and in the therapeutic process, it's all about them. And sometimes, for them to be able to express appreciation, their progress in their ability to see the therapist also as a person.
Okay, so the first question is that one of the goals with some patients is to help them become less self-centered, less selfish, less self-preoccupied, and to be able to think of others. And so if the patient giving the therapist a gift represents progress because the patient is so self-absorbed in the therapy, would that be, would you be actually sort of sabotaging therapeutic progress by not accepting the gift? So I guess it comes down to whether you really believe that's true. I guess I don't really believe that that's how therapy works. I think patients should be self-centered and self-preoccupied in therapy. It is about the therapy, and I don't know that I really recognize if you see a patient who's making progress in a certain way, I don't think we stifle the progress, but I don't ultimately believe that giving the therapist a gift is usually a sign of progress. I just don't think that's usually the case. So I'm skeptical that that's really what it would represent. If that's what you believed as a clinician, of course, you're right. You would accept the gift. But it's outside of what I think usually happens or how I think therapy works. You had a second question, you said.
Yeah, and I had to clarify specific questions in mind. Obviously, not everyone is specific.
Second question.
How do you feel about the therapist giving a symbolic gift such as a birthday card to a client that's very isolated or lost their family and has moved in their life, and that's an expression of warmth and
So, question of whether there are clients who are so lonely and isolated that the therapist gives a gift to the client. Well, all gifts are symbolic in some ways, so a card or a token of affection in some way. So I guess that I think that's again, that's outside the parameters of what I'm calling psychotherapy. I think that if patients are coming to you for affection and company or symbolic gestures of affection, I don't really think that's what our expertise is as therapists. I don't think we're better at affection or gift giving than the general population. I do think it's true that there are some patients who are incapable of having a functional relationship with anyone else, and they're able to have a new type of relationship with the therapist. That's the first person they're able to receive from and accept affection from and give affection to. But the reason that you're able to do that as a therapist and no one else is because of your boundaries. It's because you don't take gifts. It's because you don't need gifts. It's because you need nothing from the patient. So the idea that I'm going to be the one to give the first gift or get them out of I just not really how I think therapy works. I think that therapy is a space for a person to develop a new way of experiencing themselves and a new way of relating to other people that they can't in normal relationships. Other people don't need a therapist to do that. Other people can express affection, receive gifts in other relationships. If they can only do it with you, I think that you end up sort of paralyzing them, making them so dependent on you that you're the only person that they get affection from and give it to. So it's just not how I view therapy working. That's how I would see that.
Came back with a small, I don't know if it's monetary value, it's probably in the $10, $15 range, just wall hanging or something, decorative item, that was clear both from what she said and from the intent that it was a gesture of thanks and appreciation for the work that we had done until that point. And I was caught off guard because I wasn't expecting it, and I briefly toyed with not accepting it, and I just had this image of her in some marketplace in, I don't know, in India, selecting this.
Thinking of you and getting it for you, right?
And, I did accept it. It's in a drawer. It's never been displayed. She never asked about it again. It wasn't something that had ongoing. But I guess in the moment, my decision-making process was that my acceptance of it is something that's allowing her to be expressive of that thing.
So the question is about you gave details of the case that are interesting, but it's a patient gave you a very meaningful, not expensive, but very meaningful gift after when she was at a very meaningful trip in her life, and you accept, and it's a gift that is intended to be hanging on your wall. So if you were going to do that, yeah. Right, but it's to display it, and it would be displaying your connection to her, and you're not going to display the item, but in the moment you felt like unable to not accept it from her, that it would be hurtful, that she was thinking of you when she did this, and to reject the gift would have been rejecting. So I think if you felt that it would have been rejecting, you're probably right, and that you had to accept it. However, if you... And I don't know a lot about this therapy or the modalities you practice, but if you practice according to a custom or pattern where you question things before you enact them, like you don't answer questions right away, you might answer them, you might not, you want to know what the question means, then I think that you would have had more space to not accept the gift. Now, it doesn't sound like anything bad happened anyway, but this is about expanding what you can do as a therapist. So it's possible that, and as we'll talk about the frame, and I think 1 or 2 slides from now, when you follow a method that you introduce into the therapy, the custom of wondering together about the meaning of things before you just do it, it wouldn't have felt rejecting to you to do that. And you probably, now I believe you, I think when you sense your patient will feel rejected, you're probably right, and you're probably good to follow your instincts. The other thing is that, things are happening in real time, and you're doing it by the seat of your pants. So you can't really, really question your intuition afterward, because you didn't have the luxury of saying pause and then come to the Nefesh conference and discuss this with a whole group of therapists and then go back informed by that. You can do it next time. But so, if you think that you could have gotten more therapeutic mileage, or the next time you get a gift from her, you'll be ready. The question is, are you going to introduce that into the therapy in some way? Now, if you would say to her, I think you could say to her, listen, this is a very thoughtful gesture you're giving. It means you were thinking of me, and I'm really very touched by it. And I have a policy that I just don't accept gifts from patients because I don't want to be accepting some and not accepting others. So I'm not going to accept this gift, but I really see it as a very, very thoughtful, I'm really touched by it, and I wonder if you want to share with me what it means. I think there are ways that you could do that without accepting the gift, but it really depends on whether that's how you practice, and thinking about it in that way. But I trust you that it probably would have hurt her if you didn't do it. And the thing is, the gift is filed, you put it in a drawer, and that's almost to me a symbol of what you're doing mentally. In other words, you're filing it away, and you're wondering, the next time she does this, I didn't hear about the case, and we're going to move on, but there are some patients where they do something, it's like they're trying to do something to the therapy. There's it's an emotional move that they're doing to you. And so that's really comes from a primal core part of the person. And to be able to put that into language, that's a lot of what therapy is about. So that was one example of a rules-based gift. A rules-based thing. Don't go shopping together. Don't ask your patient for advice or confide your emotional difficulties to your patient. Those are rules. Those are rules to follow that help you stay in your boundaries. Don't socialize outside of office hours. It should say outside of the appointment. You see your patient, during the appointment. You don't socialize outside of appointments. Absolutely no romantic relationship or sexual contact, and I'm only mentioning that because if I don't, someone's going to tell me I didn't mention it. I don't want this to be about sexual boundary violations, but every field has now, there's no discipline in North America or Israel where sexual involvement with a patient is not at least a violation of your license agreement and grounds to lose your license, and in some jurisdictions it's actually criminal. It's considered like, the most ultimate exploitation. That was not always the case. That became the case gradually over a number of decades. It was really, there are famous stories of, there are famous psychiatrists who married their clients. The writer Erich Fromm married Frieda Fromm-Reichmann. She was his therapist, and she married him, and they appear to have had a happy marriage. But that wasn't unethical at the time. It's now unethical. So you're making a commitment. Don't hire your patient as your accountant or podiatrist. Now, that doesn't apply to former patients. You're allowed to hire a former patient as an accountant or podiatrist. It may or may not be unwise. It really depends on the nature of that therapy. But a current patient, that's considered, a boundary violation. Then there's the principle-based approach to boundaries, which is be your client's therapist. Carefully avoid being anything else for your client. Now, that hurts your clients because your clients, some of them really love you, and it might feel like a rejection for them. So you have a duty to try to make it clear that this comes from a place of love and concern for them. Like that you are, you could call it tough love if you want to, but it's not exactly tough. It's not like you're kicking them out of the house because they use drugs again. But it's more like, you are, in order to be the best therapist that I can be, you're paying me for my time financially. You're putting a lot of emotional energy into this. If I start being your friend, I'm not going to be as effective as your therapist. And that should be the attitude that you come from. So I think that is really accepted by our patients if you really believe it and mean it. If you don't really believe it, you won't be effective in explaining it that way. I probably have this on a later slide. One of the things that you can say to clients is you can say, listen, I feel like you're imagining if we had met socially, would we hit it off and have fun together? And you sense from the fact that I laugh when you tell me certain jokes and we share certain interests and we have a lot in common and clearly enjoy one another's company, you're sharing with me that you feel like had we met socially, we could have been friends. And, you might be right, but we didn't meet that way. Like, I'm your therapist, and I have to stay your therapist. Now, that's not necessarily exactly the words you're going to say, but I think that's what you're trying to convey to someone. Like, that's really the best thing I can do for you is remain only your therapist. Yes? Right. So I'm going to talk about some of this later on, but generally speaking, I would say that Orthodox communities, and there's variation among Orthodox communities also. Like a therapist I know who practices in Williamsburg told me that his patient backed into him naked in the mikveh. That's really bumping into someone, right? I mean, that's really running into your client. So now what I would say is that if you understand the dynamics culturally of an enmeshed Orthodox community, you understand that being in the mikveh at the same time with your client it actually isn't a dual relationship. Like being at the same store as your client isn't a dual relationship. You don't need anything from your client. Now, is it uncomfortable? Yeah, it's probably uncomfortable. But you bump into lots of people naked in the mikveh if you go to the mikveh every morning. You are standing, you see people at chasanas. You see people, a very good friend of mine who was living in Cincinnati, he's since moved to Toronto. I used to have chavrusa with him before Shacharis. Then we went to, that was at the Kol. Then we went to Shul, we davened Shacharis together. Then I was running the school board while he was principal, so we talked all day about problems there. Then we would daven Marv at the same place. And then there'd frequently be a party somewhere that night that we'd both be invited to. So I saw him literally like every day, constantly, all day long. And he said to me one time, he said, are you going to the Shul picnic this Sunday? I said, what, like I have to see you again? No, I'm not going to the Shul picnic. Like I can't stand it. I'm so bombarded with the same people all day long. So I think that what you do as a therapist is, you're in the community, but you maybe do back away. Like maybe you don't serve on the school board if you have a lot of clients on the school board. Like I don't write letters to the editor about politics. I don't do I have some very strong political views, and I curtail my involvement from those views because I think it'll put me in tension with half my practice. They'll hate me, and the other half of my practice will love me because they think I'm an ally in these polarized political times. So I think that you do pull back a little as a therapist if you're practicing in your community. You restrict your involvement that's going to put you in a dual relationship. I think serving on the same committee for an organization, that's really a dual relationship. You have to use your judgment. There are times when you're thrown into a dual relationship. You didn't intend to do it in the first place. Like you're working on a committee, okay, and then your client joins that committee. Do you have to quit the committee or demand that your client get off the committee? I don't think so. But would you take on a client who's serving on a committee with you? That's also a different thing. So some things are unavoidable, some things can be modified, and some things truly can be avoided. But I think that if you practice in your community, that you do have to pull back a little bit from the roles you're in. If you're, you can't be the person on the tuition assessment committee for your day school if you're treating half the people in your school. You want to treat half the people in your school, get off that committee. I think that's sort of what you have to do in some way. Yes?
I work in nursing homes, and so one role that I've sort of taken in nursing homes is basically any clients who don't have close family or friends are unable to leave the facility. So basically, many of them have not broken a good number of years. So one of the roles that I kind of took on was sort of a bridge somewhere between therapists and, I've joined with like the recreation department, started a walking program. I take some of the residents to a store that's down the block, and I want to hear your perspective on. In some ways, it is a little bit of a weird role because I'm both therapist and I do individual sessions with people, and then I take groups of residents, let's say, to a store, to beach versus down the block, for a combination of like individual activation, social integration, that kind of thing. And it is a little bit of being careful. I want to hear what you're saying.
Well, I think so the question is a person working in a nursing home where he serves as an individual therapist for some residents of the home, but he also plans activities for people in the nursing home, especially people that don't have family to visit and they're like stuck there during holidays or weekends. And is that a dual role? It sounds like it might be a dual role. I think you have to use I don't know what type of therapy you're doing with those clients, but if you think that your ability to serve as their therapist is compromised or their ability to enjoy the activities is complicated because of the vulnerability that they've developed for you as your client, or because, I don't know what goes on in the activities, but like, is there favoritism? Are they are they jealous that you're choosing someone else or sitting next to someone else? I don't know I could imagine all kinds of complications, and I think so if you feel like your therapy is compromised or their ability to enjoy these activities would be better served by someone else, then it would be something to discuss. You have to use your professional judgment about that. And I don't know the cases or the exact, everything going on. And I think some therapy in residential nursing facilities is more supportive and less insight-oriented, but some of it is insight-oriented, and you're dealing with issues of loss and grief and death and dying. So I think it just depends on whether your judgment is that they would be better served if someone else did those activities. And if you think they would be, it would be something to discuss with the nursing home administrator and put someone else in that role. It just depends on your view of it. I can certainly imagine cases where it would be. I think it would compromise your effectiveness. Yes? Okay, so the question is about the degree to which the patient seems to have really put themselves out for buying you a gift, and what are the consequences of declining the gift. So again, I think that when this patient gives you a gift, what is happening, and is it an opportunity to do something different than just accept the gift? It's human to give a gift, it's human to accept a gift. But we don't just do things in therapy because they're human. It depends on whether or not you think that there is a better intervention that would be more helpful to this person than accepting the gift. I think when we get to a section on particular diagnoses and how patients with those diagnoses can stress the boundaries, that'll answer your question more clearly. So let's get to that. I think it is definitely within the realm, especially culturally now, where a lot of people have only cell phones and not even landlines, and we communicate more by text and email. I don't think that our cell phones are really personal devices anymore. I think that they're an extension of our professional involvement. So I think it's now there are definitely limits, and there are patients who will text you too much and you're unable to do as effective therapeutic work as you would be if they could curtail themselves more. And there's some patients with emotional difficulties where they just can't help themselves from texting you all the time. So I think that a lot of therapists are burdened by a lot of texts and contact outside of hours that they're not being paid for. And it becomes a whole dimension of the therapy, and it's hard to rein in the therapy. So I think that you need to use your clinical judgment and get supervision or consultation about how to manage this. But yes, I think that all of us, I don't know anyone that doesn't ever text their clients anymore, at least certainly no one that was born after the year 1955 that doesn't ever text a client. I just don't know anyone that really practices that way anymore. I mean, I know one colleague, this is an older person though, who still refuses to get a cell phone. And he thinks that we're all doing something terrible. But my cell phone is on my answering machine. I mean, I don't bother having an answering service. I don't see the point. So I'm going to try to move on. So I want to discuss boundary issues in other realms that are not clinical for a moment, just to sort of see what happens in other domains. It'll make it more real and it'll make it more intuitive, I think, when we think of boundary issues in our offices. So people come over to your home without calling first. And I'm not talking about patients. People that stop by your home without calling first. Okay? I think, like in my city, the only person that I think should be coming over without calling first would be my daughter and my son-in-law, who live around the corner, and maybe on Shabbos if someone is out walking around, maybe that's also okay. But you've got to be a really good friend to stop over my house. If you ring my door, well, you don't ring my doorbell on Shabbos, but if you knock on my door and you're uninvited, it should be an emergency or something's weird. I'm just not available to have you come in my house without calling first. Now, other people might have a different way about them. I think on Shabbos that's an exception, but people that come over without calling first and expect you to just like be available and start socializing, I mean, that would be a boundary. That's a boundary problem. That person has difficult boundaries. A guest in your home opens the refrigerator or looks through your things without asking permission. Now, who can open, really a very good friend, like your best friend, has, refrigerator rights. But, that's where that boundary makes sense. But like that is a weird thing to do. You will feel invaded if someone does that. Invading personal space or unwanted physical touch. That is a boundary issue that lots of people do. And you feel like, now, you're not, well, you guys are therapists, so you're not normal people. But if you're a normal person, you don't think in terms of boundaries. You just feel uncomfortable, right? We've got words for all of this. We're talking about boundaries. But, like, you feel uncomfortable when people do that. Suddenly, a conversation veers into personal subjects that you're not comfortable discussing, and all of a sudden, you're being called upon to answer questions that you don't want to. And not answering the question makes it look like you have something to hide. So it's like really awkward. You're like pressured into answering questions that you don't want to ask. Your friend suddenly wants to borrow money. People overstay their welcome after the Shabbos meal. I mean, like, they just won't get out of your house. It goes on and on and on. And, you're nodding off and they're not taking a hint. These are examples of people with poor boundaries. Giving personal advice without being asked. This is starting to sound more familiar. We're among Jews in the room. But, giving personal advice when you're not asked is a boundary issue, and it makes people mad. It's insulting. It's very presumptuous. So what is the klalo shel davar? The fundamental thing these have in common is people act overly close to you or without your consent, that should say. That you have not agreed to be in that close of a relationship, and they're trying to. Now, I want to clarify. Well, all these are my examples. All these are my examples. But I'll give I'll give another example. So, in a phone call with someone, which is ostensibly about business or organizational matters, you suddenly make a very personal disclosure to that person, okay? Make a very personal disclosure to that person. Now, here's the thing. If you have good social skills and you're reading someone appropriately, that's actually how a relationship deepens. Relationships deepen through crossing boundaries. But if the person doesn't want to do that with you, then it doesn't feel warm and affectionate. It feels threatening or creepy. So it's very vague and ambiguous and subtle and nuanced to know the difference between, when someone makes a personal, to know that, like, this would be welcomed and I'm going to get closer to this person. Usually there's something spontaneous. There's, there are all kinds of nonverbal cues, and people are attuned to one another's body language and the rhythms of their breathing. And we know without knowing intellectually, we know, like, with our bodies, when someone wants to be closer to us. People want to give you a hug. Well, hugs are becoming more common. But there are times that you don't want to hug the person who's giving you a hug. You don't want to hug them. That's someone with poor boundaries. That's someone with poor boundaries. People should know when you want to hug someone. They should know if you want to hug them or not. They should know if the relationship is at the level that you could hug them. When someone hugs you who you don't want to hug, you don't like it. And, like, you probably do hug because it's now socially acceptable, but it's like an uncomfortable hug. You feel like you want to shower after the hug. It's just, those are boundary problems, common boundary problems. But it's also how relationships deepen. So it's tricky. It's not that there's, like, a right or wrong thing. You don't know it's a boundary problem until you have that emotional reaction afterward. Boundaries in Orthodox life. This will get to your question. So I'm going to make some observations about, look, I love being an Orthodox Jew. I love all of our communities. I'm not saying this to be critical. I'm trying to observe as an anthropologist, okay? So, and I'll state my assessment at the beginning so you'll understand what I mean. This is out of order. It's going to ruin the whole thing. All right, the first thing I was going to say is the following. What's wonderful about being in an Orthodox community is it's like everyone there is a member of your family. What's not wonderful is that it's like everyone there is a member of your family. That's but I say that somewhere, but I destroyed the order. It's not going to work. So anyway, seeing one another naked in the mikveh, eat and sleep in each other's houses, try to find suitable marriage matches for one another's children, see each other every single day, shul, school, simchas, live in small, tightly knit neighborhoods, scrutinizing each other's clothing. I mean, the amount of attention that goes on now in certain communities to what people are wearing, and the amount that we are looking at each other up and down from head to toe, and, are their toes showing, and how tight is that dress, and how loud is that dress, in the name of modesty. I think that's like a shocking thing that's happened. I don't know if I'm just more attuned to it in the last 10 years or it's really more severe, but the amount of attention and talking about clothing in our communities, I think, is really something. We pray together. We give each other meals when children are born, when relatives pass away. It might be similar to other ethnic communities. I think actually Muslim communities are like this so much. The Indian community can be like this in some ways. But it's not the norm that was assumed when ethics rules were drafted for psychotherapy. Like the people that drafted all the normal rules for therapy, they didn't live in New Square. They did not. They had no idea about how involved we are in each other's lives. It's just such a good slide, I wanted to show it again. So I'm going to move now to the concept of the professional frame. Okay. Boundaries are the idea of being in a professional role. Your frame is your actual behavior in space and time with patience that supports your professional boundaries. Yes?
Your last slide, when you were talking about things that are different ways we consider ourselves community, I think there's another aspect, which is that those things are actually seen as an act of living what should be an Orthodox lifestyle. So it's accepted, right? It's not only that, yes, we happen to bump into each other and praise each other, but it's the ideal that we should be living for each other. And in some communities, that ideal is valued above other things. So it's not only that, yes, we pray together and scrutinize, but it's also that the ideal way to live the life as a Jew is that you are opening your home to whoever needs, and you are cooking for people who need, and you are giving stuff to people. It's an ideal or an expectation? It's both.
Well, there's a comment that this is according to normative Orthodox Jewish beliefs, that these ways that we're so involved with one another just reflect our values, and that an ideal community is like this. And I accept that is what people say about what the ideals are. And again, I'm not trying to be evaluative at this point. I'm just observing that we have different boundaries in our community than were assumed when the rules were drafted for psychotherapy. It's just, and we'll get a little bit more about this later. What spoiler alert is that I think that this way of living does pose challenges for individuation and autonomy and individual responsibility, and it can set up very entitled attitudes toward being taken care of, and it can also really make it hard for the therapist to be a therapist, because the therapist is expected to be sort of like another service provider or rabbinic leader, or like, why aren't you making a shidduch for me? Why aren't you helping me get married? Or why aren't you, the therapist is expected to be in that communal person's role, and it really interferes with the therapy. I think that if you're in line at the Kollel store, that doesn't interfere with the therapy. Your patient finds out, that you bought lettuce that isn't Bodek or something. I don't know, whatever they find out about you. But they don't. But it isn't really. It isn't really a boundary issue. Okay. But if the client expects you to invite him over for Shabbos, or look, I'm aware of therapists that have invited their clients over for Shabbos, and they will defend that. And I don't think that that's okay. I think that that really interferes. And I think that I doubt that happens in other communities in the same way, but I understand there's confusion. Like, this is a normal thing that people do. You know, that's what they'll say. This is a normal thing to do, and it helped the person. The person was lonely, and they had a wonderful Shabbos because I invited the person over. So I just think that this, at the moment, I'm just saying this sets us up where it's like we're trying to translate the concept of boundaries and frame into, like, Mars. That's the thing, like, where people live in a different way. That's what I'm going to – so I'm going to move on at the moment. How am I doing for our – but did we just settle on when is halftime? 3:50? Is that when halftime is? Okay. So the professional frame. So it's the actual behavior in space and time with patients which supports your professional boundaries. Now, I'll just give you an example. I'll describe my professional frame. What do I mean by this? So patients contact me either through my website with an email or a phone call before I've met them. That's really the first way. And sometimes it's a relative that calls on their behalf. So I will return an email or a phone call to set up a consultation phone call by phone that will last between 5 and 15 minutes. I do more work on the phone than other people do. I do get a chief complaint over the phone and a little bit of a past psychiatric history, prior treatment history. I get more done over the phone, and I explain the process of coming in for a consultation. I explain that I'm not agreeing to treat. This is just a very important principle for me. I don't agree to be anyone's therapist before I've done a full evaluation. The evaluation, I don't know what's wrong, and I don't know whether I'm the best person. I don't know whether I'll recommend therapy. It could be that I'll see you and I think you need a lawyer and not a therapist. I don't know. So it's very important for me to say that, you know, and also there are times that I think someone else would be better, and if I don't see the person, they think I'm rejecting them, like I met them and I didn't like them. So I set up in advance that I will do an evaluation, and I'll give you my best sense as to what's going on. If I think there's a specific diagnosis, I'll share that with you, and I'll tell you what I think the best treatment for you is. And if I am someone who can provide that treatment, I'll offer to a treatment plan for you to work with me. And if I don't think I'm a person that's ideal, I will know a colleague in town who's ideal for you, and I'll make a referral, and I'll share my evaluation report with your permission for that person, so you'll have a good head start. That's what I offer to do. Then I have a form that authorizes me to be paid by their credit card, and I have a standard email that has exact directions to my office and instructions for how to push the button in the waiting room, and I tell them to get there early so they'll have the full time. I do the session. My first session is a very active session. There's not lots of open-ended time. It's a very, very active interview. My assessments tend to be usually 2 or 3 sessions and not only one session. Sometimes I'll schedule a double long, like 90-minute session for the assessment. I do a better assessment that way. Then I'll present a treatment plan. When people are in treatment, usually when people come in, I will usually be silent at the beginning of a session to let another person start. I might ask the person what is on their mind or what's going through their mind. I conduct myself that I'm trying to get my patients, and it's because of the type of therapy I do, I'm trying to get my patients to start paying more attention to their inner experience, their thoughts, their emotions, their feelings. So I'm trying to direct them to look inward rather than give me a report of what happened during the week in the news during the week. That's what people's normal. And people say, oh, nothing happened, there's nothing to talk about. No, if nothing happened, there finally is something to talk about. But people have trouble making that shift from reporting the external news to their inner environment. So the sessions are designed to get people talking in that manner. In between sessions, I'm available by email or a text, but if it goes on too long, I'll say this is just not something I can really attend to in a text. If you need an extra appointment, I could look and see what I have this week, but I can't really do that. I do text patients, but I try not to do too much because I just can't do it, and I don't have time. All of us it's uncompensated time, and if we do that, there's really no end to it because everyone would like to have our attention outside of sessions. Yes. Okay, so the question is, why do I allow any text or contact outside of sessions? I guess the answer is I think that I'm more effective as a therapist with limited contact. And when they need even more contact, I direct them to make an extra appointment. But I think that I'm a more effective therapist because of the contact outside of sessions. I think that over time, I also see people frequently. So if, I'm asking people, I'm setting up a system where they're thinking about what's going on in their minds all week long. The therapy is 24/7. The therapy is not just when they're in my office. So the fact that someone wants to share something with me outside of sessions, it's sort of expected. That makes sense to me that they would. And I'm not available to do this like on and on. And that's also often how people increase their frequency from once a week to twice a week. I say, look, you routinely have more to talk about. I think that we would be well served by you seeing me twice a week rather than once a week. It's part of my technique of deepening the treatment. So I think I'm more effective by doing that. If someone is never available outside of sessions, that's fine. Now, when people are very needy for time, and part of the therapeutic issue is that you want them to become more autonomous and depend on you less, I don't think that's going to happen until they've actually worked out the emotional issues that are making them so dependent and needy for your time and attention. So I haven't seen that my willingness to text a little or talk a little in between, that it really interferes with that process. I think it serves the process. For me, it seems to work. At the end of the session, I really do stop on time. If I have trouble getting people out of my office, which is something, that's a problem a lot of us have, I really, they have to leave. They have to leave to the point that I'll say, listen, the session is over. You're still talking. Why are you sitting on my couch? You're still, they have to leave. I don't tolerate them staying around afterward. I don't tolerate it in any way whatsoever. Some people have trouble doing that. I don't. I just don't have trouble with that. And it becomes a therapeutic issue. And that's my frame pretty much. Okay. Now, if I notice myself, deviating from the frame, let's say there's a patient I'm talking to a lot in between sessions. Let's say there's a patient that I won't talk to. I refuse to take any of this patient's texts, won't talk to them. I'm acting differently with this person than I usually do with my other patients. So that, to me, is a very helpful sign that there's something emotional going on that I'm reacting to, and I don't know what it is, okay? And that's a very important point that everyone knows is true, but people are afraid to admit it. We don't have the luxury of thinking and making decisions before we do things. You know what you have the luxury of doing? Designing a normal frame. That you can do. You can set up a really normal frame that works for you as a professional, but you can't affect your reaction in real time. Your reaction is just your spontaneous reaction. So if I find myself deviating from my frame, then I'm reacting to something, and I don't know what I'm reacting to yet. I have to think about it. Usually I will be able to figure out this patient is aggravating me. This patient insulted me. This patient is making me feel like a mommy, that I want to take care of this person that I love so much, and I am feeling overprotective. I'm having some sort of emotional reaction to the patient, and the first tip-off is that I'm deviating from my normal frame. I'm not worried about a slippery slope to ethical violations. I'm not talking about that. I'm just saying that it is how I notice that I'm having a reaction to the patient. And yes, I will own the possibility that I'm having a reaction for my own neurotic reasons, but usually I'm reacting to something the patient is doing to me. That's usually what I'll discover. So when I deviate from my frame, it's a very helpful sign that something unusual is going on. Another important concept is boundary crossings versus boundary violations. So a boundary crossing is when you do something that's outside of your professional role. I think sharing a recipe with someone is a boundary crossing. Okay, it's not a boundary violation, a boundary crossing. I had a patient who was holed up in his parents' home for many, many years, despite having a really prestigious academic degree that qualified him for really high-paying jobs. He became so ashamed of his he was depressed and didn't work for a while because he was depressed. When he was better from depression and able to work again, he was so ashamed that his period of unemployment like magnified for a period of years, and it just became this progressively larger and larger gap in his record. So we worked through that in therapy. It was very difficult, and he finally did land a really, really good job. And he came in and he told me that he got the job, so I gave him a high five. Okay? So that's not, I mean, I don't regret that I did that. It was spontaneous. But that's an example of a boundary crossing. I was outside of my role. I became like a brother, like way to go, dude. It was like that type of moment. I was in that, and I was really happy for him, and I was really proud of him, and I was also happy for myself that we had accomplished this. So I gave him a high five. Now that's a boundary crossing. That happens all the time in good therapy. That is a normal, and I think I say something about this, that I'm sorry, this is a little bit jumbled up. The frame is concrete. The frame is that pattern of behavior that I explained in real time. It's my concrete behavior. The boundary is an idea. There are no boundaries. It's like this. It's like, what is the boundary between, what is the border between the U.S. and Canada? You know, what is it exactly? It's something that people invented. Now, it's very important. You know, there's a question like how secure should let's talk about the northern border, not the southern border, okay? How secure should it be? Are we worried about Canadians coming in? And, you know, sometimes there's a river there, sometimes there's a mountain there, sometimes there's a forest. But like there are, you know, what is the boundary? The boundary is an idea. The frame would be the wall that you actually build there, and the customs office, and the barbed wire fence, and the cement wall, and the shtachim. That's what the frame is. The frame is the actual things that you do to keep the boundary. But the boundary, the border, it's a theoretical idea. It's the role that I'm in. The frame is what you do to enforce the role. That's how to think of these two things. Now, boundary crossings are human, they're normal, they're brief, they're emotionally meaningful, they're a regular occurrence in therapy. They're common, but they're self-contained, and they help and they do not hinder the therapy. High-fiving my patient was not a problem for the therapy. That was not a problem. A boundary violation is different than a boundary crossing. A boundary violation, it's harmful. It goes on for a long time, and there's no effort by the therapist to self-contain the violation, and as a result, the therapy is destroyed and the patient is harmed. They're two very different things. They're both outside of your technical professional role as a therapist, but they are two totally different dynamics that are happening. In one, the therapist is exploiting the patient, often without realizing it. And the other, the therapist is just sort of being human with the patient. Now, people can rationalize their boundary violations through their boundary crossings, but it is not hard for outsiders to see the difference between a boundary violation and a boundary crossing. Yes? Right. So there's a question/comment about how fee setting is very emotionally charged, and reducing your fee, raising your fee, charging for no-shows. You didn't mention that. That's part of it as well. It can often be the piece of information that really sets patients off and feeling that, you know, like I thought this person cared about me. I thought that we had a close relationship, but now I see it's just about money. So I do think that charging for psychotherapy is one of the most difficult developmental professional issues for all therapists. I think that all therapists are really bad at charging for their fees for like the first 10 years of their practice. In fact, one of the reasons that some people stay in clinics or in employed situations where there's an owner of the practice who charges is it frees them from the burden of charging for their fees. And therapists are, by and large, not the most assertive, people that are like good at asserting themselves anyway. They tend to be, on the other side of that spectrum of personality traits. So I think that it really requires a lot. First of all, it requires the need to earn a living. That helps you charge for your time if you need to earn a living. And it really requires a lot of time and training, and I don't think there's been very good training in most programs about fees. Now, in my program, we had very good training about fees. And they regretted what they wanted to do in my program is they wanted to give you a certain percentage of the fee that you collect to keep as a bonus. And that when you raise fees, you get a bigger bonus. They wanted to do that in part of the residency program. They weren't allowed to because it was a violation of the ACGME graduate medical training rules, so they couldn't do it. And the professors were really upset. But we had a lot of attention to charging, but it was still very, very hard for me to do. I think that's, I was, the first years of my practice were at the university. I think that I don't think any therapists are really ready for private practice when they come out of training, and fees is a big part of it. And it really requires a lot of supervision. It really requires being consistent. You have to develop policies that are fair, and the hardest thing is you have to believe in your professional value and that the service you provide is really worth the money that they're spending and that you're really helping people. And most therapists, even though they intellectually know the work they're doing is helpful, I think the first decade of their practice, they don't really emotionally, deep down in like their bones, they feel like they're scamming, that they're being paid to do this wonderful session, and they don't really believe they're helping people. I mean, I've just supervised so many therapists, they don't have confidence in what they're doing. And that's normal. It's not a criticism. I think this is like a normal developmental challenge for therapists, and that we need a lot of mentorship and guidance. Okay, so the question is reducing your fees or not making someone pay a boundary crossing? Well, I think you mean more like a boundary problem, not just a boundary crossing, but a boundary, because boundary crossings are not a problem. So I do think fees are part of boundaries. I think so it's yes, boundary. It is part of the frame, but everything when you deviate from your frame, that's a sign that something's happening in the boundaries. Like that's the signal of something going on in the boundaries. So I think that if you find yourself feeling guilty about charging or feeling just very... Now, I think if you have uniform policies to reduce your fees for financial hardship and you implement it consistently, that I don't think that's necessarily a boundary issue. I think the way it happens in reality is people don't plan for that. And then you have a certain rachmanis for a certain patient, and you end up, so you're probably being pulled by your strings emotionally. And I don't really think that people can do this in a good way when I think people need a lot of mentorship for this early in their careers. Yes? Apparently you didn't get past it in therapy, though. You feel you got past it there. She didn't get past it. I believe you felt it was accomplished in those years of time, but the patient regressed. So the comment is about, I mean, there's so much in your question that, like, I could go on and on forever about it. It would be the whole talk. It's a perfect question of a borderline patient who used to demand hugs and demand all kinds of, and you really felt that you had gotten the client to understand the boundaries, and you're very surprised and disappointed that the client is suddenly demanding hugs again and intruding herself in your personal space or in your home or in front of a bunch of people trying to hug you in public, so you can't really deny her the hug. And so I think, I mean, I didn't hear about the case, but I think that's probably an example of someone who has been, you've trained sort of intellectually to, under normal circumstances, follow the frame that you prefer, but when she's in an emotionally charged, less regulated situation, she regresses to her former ways of doing things, and that she still has borderline personality organization. And I think that that's, it's probably just the fact that she has more to do. And I think that, you know, patients, well, all people, not just patients, but all people regress when they're excited or when they're stressed. What do we say? That there are three ways we really know some. Bikaso, Bikiso, Bikoso. When they're angry, when they're negotiating about money, and when they're drunk. So this is like a situation like that for her. She's in a public setting with you, and this overcomes her. She still has really deep longing for you in some way, and it isn't done yet. It's you can have a long, productive therapeutic relationship with her for many, many years. It's a bracha, I promise you. What time is it right now? Oh, we have plenty of time. Okay, Sylvan. Interesting question. Are therapists different than the service providers in many other fields that don't seem to have that difficulty? The first thing I'll say is I don't work in other fields, and I wouldn't be surprised to discover that other people do have trouble charging for fees. I don't know that it's not obvious to me that other people don't have trouble for fees. The second thing is I think therapists are weird people. I think therapists by and large, therapists have trouble asserting themselves, trouble charging. I think that therapy is also, there is something about serving someone emotionally with emotional difficulties that there is something about charging for that is just inherently, like in terms of just sort of normal human feelings, it's so contrary to what your normal human intuition is. I mean, the normal human intuition is if someone wants my advice and wants my help, I feel honored and I'm happy to do it. And then it goes on too much and I get aggravated and I want to get rid of them. Okay? Therapy is so different. It's like you're in a situation where people's humanness and emotions are spilling out in ways that are more intimate, more open than anything else, and you're going to interact in a way that is in normal circumstances not polite, and like you're acting just so counter to your intuition. And I think there's like charging for your time sitting with someone and talking is like it really takes a long time to understand, like that's your professional service you provide. Now, if I have a roofer, and I would say to my roofer, I know he has materials, he has labor, he has like a straightforward thing that he needs to do, and he's going to do that. He gives an estimate and he provides it for the job, or a plumber, or I think like therapy is so different than that. It's like let's say you have a roofer and you say, I'm having leaking in my roof. Can you look at my roof? And the roofer says, well, yeah, I see there's a lot of leaking. Here's what I'm going to do. I'm going to go onto your roof once or twice a week for the next 6 months. And I'm going to take off some shingles and put on some other shingles, and I'll send you a bill once a month for it. And we'll just see what happens. We'll see if I can help you with your roof. And that's like what we're doing. It's hard to concretize it. Let's think of it compared to medicine. They develop these procedure codes for every medical service that's provided. It was very hard to develop procedure codes for psychotherapy, and they're really stupid codes. I mean, they're like a company will complain, like, well, you said that you did a 99214, but it was really a 99213, and we don't. Like, leave me alone. I'm spending X amount of time with someone. We have to quantify it. It's hard to quantify what you do as a therapist. I think it's different than other professions. That's sort of my al regel achas answer. Yes.
sliding scale. You know, you met a person the first time, and you did a sliding scale. Like you set a certain fee, and then time goes on, you found out the person, summertime takes the whole family to China. So then you got some feelings in China. So these sliding scales make sense.
Okay, so do sliding scales make sense? And you're giving examples where you give someone a sliding scale and then their conduct and their lives seem to indicate that they should be able to afford much more than they do. So I don't have a sliding scale in my practice. If I see someone for more than once a week and I think they really can't afford it, I will be willing to discount the second session, or if I see someone for 4 times a week. Like I have someone right now who comes 4 times a week, and she pays full fee for 2 sessions, and the next 2 sessions are free. Why do I do it that way? Because if I'm out of town and I only see her twice that week, she can afford the same amount. If she goes out of town, like I'm not going to accept a discounted fee if she's out of town and only pays for 1 session. I really do believe that that's a fair fee for her. And I'm willing to do that to support psychoanalytic work. I think it's very few people that can afford to pay my full fee 4 times a week. And I don't want to only treat like the uber wealthy. I think that would be a really weird practice. And actually, I know people that do that, and they become very weird. Did any of you know therapists that only treat the wealthy? It's a weird, that should be another talk, working with the uber wealthy. But people that treat only the uber wealthy, they become very weird therapists. I don't want to have a practice like that. What was that? Well, not necessarily, actually. They don't. I mean, there's only so much you can charge, and but if you do that, I mean, like this therapist that was treating Michael Jackson and seeing him 12 times a week. I mean, he killed him with medications. I think money. I don't want to practice like that, and I want to treat people. So I do that, but I don't have a sliding scale for once a week or less. And I think a sliding scale is really very difficult. I think you have to develop some sort of like objective criteria. And it's sort of awkward. I mean, if you have a clinic and you have staff that are there and they ask people to turn in their income tax, you have to provide your assigned 1040 for the previous year, and there's just a formula that you follow, so it's impersonal. I think that that's doable, but I don't think that really happens with a private practice one-on-one. So I think a sliding scale, I mean, people seem to do it, and they seem to be, but I don't think I would know how to do it. I would not personally know how to do a fair sliding scale. And when I worked, I'll tell you what cured me from even thinking of that. It's my work when I was on the tuition committee at our day school. I was lied to by so many people about their income that I became very, very jaded. And it's like there were people that went to Eretz Yisrael on trips that I cannot afford, who we had given like huge discounts on their tuition. And so I feel that we are lied to by people all the time. And so no, I don't do a sliding scale, but you'd have to talk to someone that's good at it. I don't know how to do it, and I hope not to need to introduce one. Yes?
Something about him, when a patient calls and says, I have medicine treating, I have anesthesia, well, that's okay, I can pay. I say no, and I say it's good. All types of medicine. But I can't, because I'm sorry, I'm not going there. How do you schedule that?
All right, so comment is that you are not a Medicaid provider, and if someone says that they can pay privately but they also have Medicaid, you won't agree to do it. So you seem not to be living in Muncie or Williamsburg, or you don't have a Jewish clientele. Right, so, okay, so I think that that's sort of a medical, legal, ethical question. I guess it's a boundary question because you may be colluding. I would probably personally look. It's a cultural issue. There is a segment of our communities that just pull a lot of shtick and get as many services as they can, and they kind of feel like they're cheating the czar. So who cares? It's like that's. It's like fair game. It's like whatever you can get away with, it's totally allowed. And so it's culturally normal. I don't think that the people who are doing that, I don't think it's on their radar as like deception or lying or an ethical violation in some ways. So I totally respect how you're not able to participate in that, and you don't need to participate in that. But I think it's culturally normal. So if you're working in a population where everybody does that, you just sort of accept that that's the population. That's what I think people say. That's the population that you're working with. But I'm worried about, I pray that therapists pulling shtick with public funding is not going to be like the next scandal for our community, because there are therapists that are doing stuff. I mean, it's just so rampant in our communities that people are they're being paid sort of black market at the same time as they're also charging for Medicaid services. I mean, it's happening a lot in our communities, so I think we have to be cautious about that, and I'm worried about that happening. I don't have that problem. People where I live that qualify for Medicaid truly can't afford to see me. Now, there are people who will qualify for Medicaid, but their families will pay for their treatment. So I think that's usually what's going to happen. I don't think you're dealing with people that have like a huge cash business and are living really nicely, but they qualify on paper for Medicaid. I think it's usually like the parents will pay or a sibling has money. So I think that's what happens with a lot of therapists. But that's just, look, that's the reality of our communities, is people, they manage to get transportation paid for. They manage to get all kinds of things paid for. And we see it as gaming the system, but like that's just like culturally normal. That's my view about that. Yes.
How do you negotiate the boundary of calculations that are due emergency or pseudo-emergency?
The question is about pseudo-emergencies versus real emergencies. Right. So I think that real emergencies versus pseudo-emergencies is not a boundaries issue. I think it's a diagnostic issue. And I think that if you have training in an inpatient unit or an emergency assessment center, I had a lot of emergency training. So I just think that I'm adept at knowing when there's an actual emergency versus a pseudo-emergency. But I don't think it's a boundary issue. I mean, I think that if you think your patient may be suicidal or they're frightening you by the things that they're saying. Oh, okay. Okay, so I misunderstood. The question is about when patients cancel for an emergency. So I'll share something in my frame that I should have before. So if I'm going to take them on as a patient, I say, I want to discuss with you some policies I have for my professional fee. So I have a 48-hour cancellation, and it's not just 2 full days, it's 2 full business days. So if you have an appointment at 3 p.m. on Monday, you have to notify me by 3 p.m. on Thursday. And if you don't, I have to charge for the session. Now listen, if you see me over time, there will be times that you really have an emergency and you have to, or you may be sick, or your child may be sick, or your boss says there's an emergency meeting that you have to attend. And I accept that that's valid and that you do have to attend. I have to charge anyway because your emergency, I make a living through my professional time. So if I give you an appointment, you've purchased that time and there's no refund after 48 hours. What I will do is I will endeavor to find another appointment later in the same week, and if you come then instead, you can have that without an additional fee, so you won't be charged a no-show or late cancellation fee. And even if you forget and have a no-show, so that's how I don't like charging for no-shows, but I don't say this, but I even more dislike not being paid for no-show than charging for no-show. I have to do that to afford it. I think people cancel all the time. And also, the nature of my practice is I see a few patients very frequently. So I don't have, tons of people I can just, squeeze into an appointment. If someone cancels, it really puts me out. And I see some people for double sessions, and so if they cancel, it's a lot of money that I'm out if they cancel. I really have to charge for my time. So I tell them, and I say, I hope you consider that to be fair. If not, we can talk about it, but that really is my policy. And people say it's fair. What'd you say? If I cancel for an emergency, I cancel for an emergency. I think if I neglected a patient, I'd probably give them a replacement appointment free. But if I cancel, what can I do? I'm unavailable. I'm unavailable. I mean, it's. Oh no! I'm not charging them. Is that what you're asking? Do I charge? No. If I cancel for an emergency, I'm not charging them. Yeah. If anyone has figured out how to do that, let me know. Not on microphone, not recorded, but it's in this. Yeah, but no, I don't charge for my own emergencies. Someone has their hand up and back, so he beat you. But that's the boundaries we've set up. Yes. Okay, so so in other words, someone cancels frequently legally. I don't think I have a hard and fast policy like number of sessions. Now, my analyst had a policy. He said, if you cancel more than 10 appointments in a year, then I need to charge for all those appointments, even if you cancel in advance, unless I fill it with other people. But now he has only an analytic practice. Everyone he sees he's seeing everyone he sees like 4 times a week. So if I cancel, let's say that I travel a lot and I cancel 20, 30 appointments in the course of a year, he can't afford to cancel that much. So that was part of the policy. I felt it was fair. I felt that was fair. I have a patient right now who's an analytic patient, but he cancels very frequently due to his travel for work. It's actually the same patient that I gave a high five to that I was talking about before. So I came up with something for him, which is that he has to pay for a minimum number of sessions per month, whether he's there or not. Like I just cannot, he knows like the week before whether he's going to be consulting out of town or not, and I can't afford to do that. And he said that it was fair. I also offered to do sessions by phone when he's away, but he doesn't want to. So I think that you just, I think the boundary would be, I'm going to be honest with you about what works for me financially, and you tell me whether it's mutually respectful to you. It's got to work for both of us. If it doesn't, no hard feelings. If it doesn't work for you, you could find someone that can handle a different policy. I can't handle it. Like I can't cancel. I can't afford to keep my doors open if there's that much cancellation. And I'm very open that these are my financial needs. The policy, like this is a policy to protect me financially. And so, yes, I understand you'll have legitimate emergencies, and it's not a judgment as to whether it's a legitimate emergency. It's really what my financial needs are. And that's what I say it like that at the beginning. I haven't had people bothered by it, actually. I haven't. Yes.
If you say that I'm charging you for my time, but then if you can find another spot later on in the week, I'll give it to you and I won't charge you for that. How do you reconcile that?
Well, how do I reconcile that? At the moment that I give another time open during the week, it's open, so it's not going to be time. I'm not losing that professional time. Like it happens to be an open session, and I do it because it allows me to both protect my professional time on the one hand, and I think make it more palatable for the patient, because like if a patient, when my patients cancel, they're not canceling because they just, they're bored or they wanted to watch a movie. Like they really do have things that are coming up. So I think that it's like good customer service. I'm giving a pretty tough policy. Like if I don't have a 2-day business day cancellation, you have to pay me my full fee for 45 minutes while I'm going to basically play guitar or, call David Brownstein on the phone to schmooze. Like that's what I'm going to do. Okay, that never happened. But I'm going to, it's a pretty tough policy. So I'm happy to have an out that works for both of us. And I think that it gives me, I feel more comfortable with the policy. Like it protects me, but it's like more forgiving for them. I think it's like good business practice. I think that it makes people more accepting of the fee. So it works for me. I don't think it's unfair, It's true that in theory, I might have found another person to fill that other time. So, okay, but I'm willing to accept that. If they skip the other appointment, then, okay, maybe I have to, I don't know if I probably wouldn't double charge both, but I would be reluctant to do that again for someone. It's $3.50. Okay, so we're going to take a 10-minute break, and we're going to start at
And I still have my license in California. And basically, clients need to, they call me over the phone here and there because we have an established relationship. That's not an issue. I have one client that is in a very difficult relationship with her husband. And she always, we make my client, I'm saying, and it's not a problem. Obviously, it's part of the great objective. She's expecting a baby now for first hearing. And she tells me, she says, you're coming when I have
You're coming what?
for the bris.
Oh, she's inviting you in as a guest.
She says, I'm going to pay for it. You're going to come. I know I'm not going to.
Are you still her therapist, though?
I'm her therapist. It's not, in my mind, it's not negotiable. I'm not going to.
All right. Okay. And the question's what?
No, so, like...
How to turn her down?
I actually want to hear, I told you before, I want to hear from you.
How to turn her down?
How to turn her down, what would you do? Because I think... funny faces and what is going on and who knows what else, you know.
Well, I mean, I'm trying to think. I don't know the case, so I can't comment on what I think is going on because I don't know the case. And you can't tell me the case in 5 minutes anyway. So if I can imagine there being situations, I mean, it's obviously easy to imagine why it would be a boundary problem and you shouldn't do it. But I can imagine cases where you're in a community and a bris is a public event that everyone goes to in the whole kahila. And so the fact that the therapist also goes to the event is not really a, you know, the issue is that it's like, you know, flying to California and she's paying for your ticket.
She has to pay for my ticket. And for me, time is also, but like I'm saying,
Right.
If it was locally, I don't have
Right.
a problem. I make an assessment, I discuss it with the client, but not to people's weddings or not to people's weddings, whatever. You know, making assessments is not an issue that's all the time coming up. And I discuss it with others, with my group, but that's not the issue. The issue is she wants to fly me in. By her, it was not even a doubt in her mind.
That you're going to go.
Yeah. It's like, it would be really nice, which my husband will do a vacation, you know? I'm just saying,
And she's your current patient, still ongoing patient.
She's my patient for 7, maybe even 8 years now.
But still active treatment with her, right?
This is going to be a long time. She's in a very difficult relationship.
Right.
Very traumatic childhood. My father is very sick.
Yeah, I think it's too much. I think it's too much. You become her guest. You're her guest, and she's taking care of you. So I think it's like way outside your role as a therapist. And the other thing is there's like, you know, she also might really like, you might have very awkward moments. You might get offended by her. Like, you know, it's a lot. Like you're making yourself very vulnerable to her to fly there and let her take care of you. And you know, and it's also, I mean, I think I'd probably say, listen, I'm sure I'd have a wonderful time, but this is just too much personal relationship contact outside of our therapeutic frame, and I don't feel right about doing it.
Right. But I do want to tell you, I've been back to LA since, and I have not seen her.
Right.
I've had sometimes people that I'm not where she said, I know
Right.
you knew those people because this kid was in my class. You know?
Right.
In her class and whatever. And I didn't say anything.
So I want to check with David about when we're supposed to restart. David, sure, you're. David, what's the agenda now?
You're back.
Are they ready? Is everyone? I think she was waiting, but yeah. Oh, I'm not on with them, but that's interesting, yeah. I'm not on the same network.
We're going to resume in 1 minute. Please be seated.
Teaching them what a healthy relationship looks like? Is that the intervention?
No, the intervention is what is the emotional What's the emotional exchange that's going on that they want to give you a gift? That they want to give you a gift now? What's happening that's driving them to give you a gift?
The emotional exchange between me and the client.
Yes, that's inducing them, that's causing them to give you a gift. The gift is a response to something that has to be understood and expressed.
So I thought it was the point of conversation to discuss what the role of my role is.
Dove, do you want to tell everyone out in the hallway to come in? Where you're sitting? Okay, so we're going to continue if people come back in. So, okay, so Sipora Wallach is making a comment without raising her hand first. All right, so now I want to get back a little bit more to the purpose of boundaries, okay? So the purpose of boundaries, this is a little bit, oh, that's off? Yeah, that looks like it's right. Warming up. Okay. So the purpose of boundaries in an ethical sense is to protect the patient from being exploited. But I want to, as I indicated before, I want to think about the purpose of boundaries from a clinical perspective for the therapist. So from the therapist point of view, the boundaries allow the therapist to function at the best of his or her abilities. That's really what the purpose is. And what do I mean by that? This is an observation. Tell me if you agree with this. This is a very sad thing that I have had to acknowledge about myself. I'm a better person to my clients and patients than I am to my spouse or my children or my parents, definitely than to my neighbors or my friends. I mean, it's not even close. That I'm kinder, more patient, more thoughtful, more sensitive to their needs than I am to my own children. Yes, Yitzi.
I'm going to challenge you. You might be kinder, patient, thoughtful, or sensitive to your patients more than your children. It doesn't mean you're better for them. In other words, your job as a parent is to be a human being. And being a human being means that if they need to go through, they need to be attached to all my humanity. And as a therapist, my job is to be kind, patient, thoughtful, and sensitive.
No, I think I'm better. Yeah. Well, I am getting into my own personality. No, I mean, if they'll answer the phone if you call. So Yitzi's comment is that your job as a therapist is totally different than your job as a parent. And, parents should lose their temper from time to time, or parents have to, struggle with their children. And it's a different role, and the fact that you are more regressed, that you have to reward and punish. You have a lot of duties to your children that don't apply to your patients. It's a totally different role. So you disagree with comparing. Okay, so now Yitzi and I are in violent agreement, and I'm just going to continue. He'll see where I'm going with this. But now Yitzi is just ahead of me on the slides. So on the slide, but I agree with what Yitzi's saying. But in terms of my capacity to listen to a patient lose his or her temper at me and treat me rudely, I am able to think about it, not react, listen in the most generous way possible with a patient in a way that I can't with my children. Now, the thing is, though, even though what you're saying, Yitzi, that I have a different role, I do think if I could be more like that with my children at times, I would be a better father than I have been. Now, why can I do that with my patients? Well, here's just another person that says, Erwin Hoffman says, psychotherapy treatment and often the patient actually do nourish some of the analyst's more ideal qualities as a person. That therapy is this role where you're able to become like your ideal self. You can actually be the best possible person that you're capable of being more of the time in therapy than in the rest of your life. Now, yes, Yitzi, you're correct that I'd be a really bad dad if I became my kid's therapist. But I have patience and control of myself in therapy that I don't have with my children. It allows the therapist to stay safe, calm, reflective, and less reactive. David.
Do you or how do you respond to a patient's awareness of that? What I mean is, I have one client in particular who has said from time to time, she's so calm. Now she's not calm, so there's a contrast. She's so patient, and I have said things to the effect of, and she and I have been working together for a while. Maybe that makes it better or worse, I don't know. But I have said things to the effect of, I only have to do this 1 hour at a time. In other words, I can hold it together. I can be present. I can be in the role of a therapist in my
Right. So the disclosure in question is that you reveal to your patients information, you share with them what you feel it is about being a therapist that enables you to be in a certain reflective and calm state that, it's not just that you're blessed with some like beautiful temperament or set of middos. It's the therapy itself, the setting of the therapy is what enables you to do that. And you find it helpful to share that with patients in some way. Your thing is I only have to do this 1 hour a week with you, but I don't know that that's...
To the extent that it reflects that I'm a human being. I'm not some kind of, super...
Yeah, you're not an angel. You're not an angel who doesn't have...
Everybody else in her life.
Right.
That can't tolerate her.
Right. So that's a clinical judgment that you've made, that it's helpful for the patient to understand that this like wonderful version of you that you're getting is because of the therapy role and not because you're an angel in some way. Like you've concluded. So I don't doubt your clinical judgment about that. I think I probably don't think it's because it's only 1 hour a week. I don't think that's what it is. I think what it is that you have you have no expectations or needs from the client other than your fee, so there's really very little pressure on you. If the patient starts to misbehave, okay, I'll give an example. Okay, I have a patient, this is a hard thing to share with a religious crowd, but I'm going to share it with a religious crowd. So I have a patient who went back to college, and the patient with borderline personality got a lot better, I thought. Kind of like your patient who got a lot better. So, and she became, I won't say exactly what she became, but she got a job in a hospital, okay? And she started having sex with, like, so many men that worked in the hospital, literally, like, in broom closets, and she got a reputation as being this, like, really slutty, crazy woman. And she told everyone that I was her doctor. And it was really embarrassing for me, okay? And I did feel like, like that really irked me. It was like my gaiva, my wish for, a reputation. And like it really, like I felt like I had this like bad child out misbehaving in public. And it really irked me. But I still think that I kept my composure, in ways that if it were, my daughter, Khalila, that I would not be able to. I mean, I think that it's very different. It's very different. Like, I expect people to misbehave. It's like, you come in my office and you completely lose your composure and you act in a crazy way. Well, that's what I do for a living. Like, that's what I'm expecting. Now, I think that for me, we all have our issues that push our buttons. I think for me, what pushes my buttons would be when patients are really, really mad at me because they feel that I'm neglecting them. There's something about that. Now, I think there are other people that do better at that issue than I do. Like, that's one of my countertransference vulnerabilities. That's like something where people have got me in that way. But I think in general, you know, it's my boundaries, it's the limited role that I'm willing to play, okay, that enables me to do a really good job, because it's like very clear. Now, I'm not saying that every intervention is clear and what the formulation is going to be is clear. There's a lot of very, very difficult work in therapy to do, and there's a lot to learn. But I don't need from my patient what I need from a friend. You know, if I have a patient who's starting to mistreat me or treat me unfairly, I can, you know, it's much easier for me to see that as coming from their problems, their emotional problems. In fact, I've become much more understanding in the rest of my life because I think that's what I do. I think when friends disappoint me or get mad at me, I think I now start to put on a therapist hat and I start to, you know, like Yitzi must be having a very bad day that he told me he thinks I'm a better father than I said I was in front of everybody, or something. Like I start to wonder like what's going on with the other person from skills that I got from therapy. I think it really, having really clear boundaries is what keeps you grounded and normal and sane and able to put up with all kinds of insanity. Like that gives you the resilience to do that. It's just, that's what protects you more than anything else. It helps us notice the pressures that the patient is unconsciously exerting on us. You know, like I've got a very typical way of conducting myself, and when I see myself suddenly like going outside of what the normal parameters are, that's like a wonderful tip-off to me. That doesn't work in like a friendship, you know. My friendships are not so ritualized the way therapy is. But it's the boundaries that give me that ability to do that. So I want to talk a little bit about projective identification and enactment. So these are two different terms for really the same phenomenon. And it's a difficult and deep concept that some of you are familiar with and some of you are not familiar with. But it's the following phenomenon. It's universal in human beings. It probably starts in infancy. When you hear your baby uncomfortable and crying, okay, you feel uncomfortable. When your baby is scared and in pain, you feel some fear and pain along with your baby. That is a normal, especially maternal, but it's a normal parenting reaction. Like there's an expression that you're only as happy as your least happy child. Has everyone heard that expression before? There's something about, you know, our children's primitive emotions that get inside us. It's not just with your children. That's just where it's very obvious. If you are very, very fearful, let's say that we're in this room right now, you'd start to smell gas, like a gas leak, and you're worried that there's like a toxic fume coming in the room. And no one else seems to be worried. You'll be very, very anxious about it. In fact, you will make your anxiety so known. You know when you'll feel less anxious? When other people are anxious about it too. Like you get other people, we infect our feelings inside of other people, and they share the burden of the feelings with us. So there's two different terms for this. One is called, they come from different theoretical perspectives. It's beyond it. But projective identification and enactment. Most of the times that you feel uncomfortable as a therapist are when your patient is having some version of that discomfort and they're behaving in a way that they're putting it inside of you. I'll give you a couple examples. A patient feels really ignored and neglected. Patient will probably start to do something that makes you feel ignored and neglected. And you don't know that that's going, you don't know what's happening. You just feel like, man, like she's not listening to me today. She seems so like dead today, like she's not responsive. This was a very unsatisfying session. And this may go on a long time. She may forget about appointments. She may, but you, this can take weeks or months for you to wrap your head around. But you have developed this real sense of emotional discomfort with the patient. And what you need to do is figure out what's going on. Usually the patient is having an emotional reaction, and they're getting that emotional reaction inside of you as to in terms of how they're treating you. Now, the most obvious example of this would be kids who are abused and brutalized often become bullies, or they torture animals, because there's something about getting that fear or terror into another person that relieves them of their burden in some way. So this is one of the most important things that we have to get in touch with that's happening in our patients. And if we don't have really clear boundaries, you'll never have the opportunity to notice this, because you'll just be reacting or doing one thing or another, responding to your patient to try to you have to really hold yourself very, very steady in order to savor those feelings that patients are putting inside of you. Our sickest patients are patients that have the most trouble in their interpersonal relationships and blow up their friendships and have fallings out with their family and just have one, disappointing, hurt, disaster, or abusive relationship after another. Those are the patients that put those feelings inside of us. And we try to be as nice as possible to those patients, repair them, show them that the world is kinder, but that actually doesn't really ultimately work. We have to actually participate in those wounded feelings, and the patients bring that by wounding us in some ways. And boundaries are what allow you to notice that. Boundaries are what keeps it very, very safe. If you have very, very clear boundaries and you know that you're never going to do anything other than act as the patient's therapist, it's much safer to feel angry at a patient. It's much safer to feel seduced by a patient. If your boundaries are really, really clear, it makes any feeling in the world a safe feeling. If your boundaries are not clear, then your feelings become very dangerous. And that's what happens with a lot of our patients. A lot of our patients have trouble distinguishing between emotion and action. If you have a feeling or a thought, it's automatically a behavior. Your boundaries keep all of your feelings. I mean, basically, you're still going to just be sitting and talking. I mean, that's all you're going to do. An occasional text or phone call. And that's already, I forget his name in the back, that already bothers him. I mean, that's already too much for him. But an occasional... I'm kidding around with you. But you're not going to be doing anything different. If your boundaries are clear, that's what's going to happen in the therapy. It really makes your ability to feel the depth of the emotion much safer. That's the purpose of the boundaries. It keeps you sane and normal and grounded, regardless of what the patients do to you. Yes. So why doesn't having less clear boundaries help clarify what the emotions are? If I'm responsible to make you feel less lonely, for example, let's say that's you come to therapy because you're very, very lonely, okay? If I now am responsible to make you feel less lonely, that would be a boundary problem. I mean, what I'm going to do is I'm going to listen to you. I mean, if you're lonely, I'm going to try to figure out, what does it mean that you're lonely? Do you have no one in your life? If you have no one in your life, why do you have no one in your life? Have you scared everyone away? Are you so socially inhibited you can't make friendships or relationships? Or do you actually have a lot of people in your life, but you're so needy for more that you feel lonely? I don't know what it is, but I'm going to try to figure that out with you, and I'm going to try to figure out what's wrong and what's happening. Probably you're doing something to people without knowing it that is pushing them away from you. Or you're doing something to yourself that's making you dissatisfied with the relationships that are there. But if I have to now come up with solutions for you and help you not feel lonely anymore, then every time you're lonely and frustrated, there's new pressure on me. I have to somehow gratify and soothe your feelings in some way. And that's an example of where if your boundaries are not clear, I'm your social life director. I give you advice about how to do this. Or I call you when you're having a bad day, when you're lonely. Or if I become responsible to, soothe your feelings in some way, then I'm going to be much less effective in figuring out with you what's wrong. It now becomes, I mean, there was one of the examples, I forget it was you who gave the example about the gift, like giving a gift to a client. So does that mean now if the client is still feeling lonely after that, I didn't give a good enough gift, or I have to give gifts more? Like it becomes now about like, you know, like their behavior, their feelings are now a response to how good I'm being to them rather than being able to listen and sit with their feelings. That's when I get to another slide, it may be a little clear, but that's the best I can answer at the moment. So challenges to boundaries. Personal questions. When patients ask you personal questions, that is something that a lot of therapists struggle with. And I want to talk a little bit about that. So someone give me an example. Imagine you're a client and you want to know something personal about me that you ask, that you think I, you know, and how would I handle it? Just come up with something. Yes. Okay, that's a good example. I didn't inhale, but I tried. So have you ever tried pot? Someone wants to know if I've ever tried pot. That's a good example. And that's a question that patients have asked me before. So would you answer that question, and why not? Would people answer that, or would you not? Can you imagine there are patients you would answer it with? Or Zipporah says no one. You don't want anyone to know what you're up to? Last Nefesh conference? Can anyone think of anyone you would answer that question for? You can think of someone you would answer it for. Okay, so if you answer the question as to whether you tried pot to a younger person, whether you say yes or no, you're in trouble. So that's an interesting, we'll think about what that means together. So I would say the following. The first thing is, you know, what's the modality of therapy you're using? Are you using a modality of therapy where you use the person's question and not answering the question? Is that a therapeutic technique that you use? Okay. So there's a lot of confusion about this because there are certain modalities of therapy where that's not a technique that you're using. So I think whether you answer a question or not is not a, you know, if I don't answer a question, I don't think it's a boundary issue. I think it's a technique issue. There are people that want to know whether, so the example that I often give is I have a patient who he's now 30. He's still a virgin, and he has a girlfriend now who actually wants to have sex with him, and he's afraid to have sex with her. They're fooling around, but he's afraid to have sex with her. He wants to know, and he also feels very ashamed that he's still a virgin. He feels very unmanly. So he asked me my age, how old was I when I lost my virginity? Okay. Now, why aren't I going to answer that question? The real reason I'm not going to answer that question is it's private, sensitive information about me. Like, I don't want him to know that. I don't care whether it's therapeutic or not therapeutic. Like, I don't want him to know that. I don't want patients to know who I voted for. Again, I don't want half my patients to hate me nowadays. I don't want patients to know. There are things that I want to keep private for my own private reasons. So I'm not going to answer those questions because I want it to be private. I think it's good to know that you want certain things to be private. There's nothing wrong with that. You are allowed to have privacy from your patients. So if you're not going to answer something because it's private, be very clear about that to yourself. Now, I want to know what he imagines the answer to my question is, and I also want to know what it would mean to him if he found out that I lost my virginity when I was like only 12 years old, or that I struggled with sexuality also, and I wasn't able to consummate one or two marriages because I was so anxious about sex, and I finally, with difficulty, consummated a marriage in my mid-30s. What would it mean to him? Or if he learned that, you know, I'm somewhere within the, I think 90% of the population loses their virginity between ages 15 and 25 or something. If I'm somewhere in that normal range, what would it mean to him to find all that? I want to know what that means to him, what it would mean if he found those things out. I'm not going to answer the question for my own privacy reasons, and I want to know the answer to the question. I want to know what he imagines the answer is or what it would mean to him. So I'm probably going to say to him, well, listen, I'm not going to answer that question because it's private. But, I'm really wondering what you imagine the answer is and to what it would mean to you. And I might spell it out. Someone wants to know if I'm gay or if I'm straight. I don't wear a wedding ring. At the time my wife and I got married, the Rav who married us, it was very important to him that there's not a double ring ceremony. That's according to his opinion that presents a problem with the Kiddushin, and so I never wore a wedding ring. So people don't know if I'm married, they don't know. So someone wants to know, am I gay or am I straight? I really want to know what they imagine and what it would mean to them if they want to know. That's the kind of therapy that I do. So I'm not going to answer because it's private, but I want to know. So I'm very clear this is private information. Let's say someone wants to know, in the first session, someone said to me, Dr. Klafter, before I proceed, I need to know, do you have children or don't you have children? Now, it's not really private information, actually. It's actually public information if I have children. I would tell a stranger at a cocktail party if I have children. Okay? I won't tell a stranger at a cocktail party how old I was when I lost my virginity or if I smoked pot before. That's not. So I said to this person, well, I can answer your question, but before I answer your question, it sounds like it's very important to you, and I'd like to know why it's so important. What is it that knowing that, let's say you found out that I don't have children or I have a large family or I have a new baby, what would that information mean to you if you found it out in either way? So she said, well, I had a therapist who was always criticizing my parenting. For years and years, she criticized my parenting, and I found out she doesn't even have her own kids. And I was so insulted that she's so judgmental of my parenting. Now, I don't really know that therapist is so judgmental because, you might have a lot of criticism of her parenting too when I get to know, but that's how she felt about it. So I said to her, well, listen, I'm glad you told me. I do have children. But even if I didn't have children, I would hope that you'd be able to work with me, but I would be very sensitive to the fact that you do not like being criticized about your parenting. You feel like it's unfair. You feel like you're being judged. But, I got that information. Now, there are times that you might want to never answer. I don't think it matters. To me, the question of whether you answer is less important than being able to discuss with them why it's important. So for me, it's been very helpful to know when I want something to be private, I say that is private, and I'm not going to tell that to you because I want it to be private. Right, I need to keep that private for myself. Will not answering the question help you learn something important? Will answering be more helpful? That's a clinical judgment that you use. In psychoanalytic treatment, the standard practice for many, many decades was to not answer questions because it keeps open the patient's fantasies about you. Like the patient's imagining that I'm gay, or the patient's imagining that I'm straight, or the patient's imagining that I'm celibate, and it may change from time to time with what's going on. So the concept is you want to keep a fantasy space open, and you never want to impinge on the space. As time moved on in psychoanalysis, we realized that patients, no matter what you tell them, they keep a fantasy space open anyway. It's really whether you can just allow them to imagine things, and allow them to imagine it out loud with you. But what happened, which there was a lot of confusion about for many years, was since it was standard practice to never answer questions. If you did answer a question, you must have boundary problems. You must be confiding in your patient. You're making the therapy about you. Why are you talking about yourself in the therapy? Why? This is supposed to be about the patient, not about you. And people were accused of basically having boundary issues if they talk about themselves in therapy. Now, there are therapists that talk about themselves too much in therapy, and I think they do have boundary problems. But answering a question or not answering a question is not a boundary issue necessarily. I think, there's a difference between, sharing and scaring, okay? So to me, to answer the question, how old were you when you lost your virginity, that's really, I can't see how that's going to serve any therapy. That, to me, is just way too much. But you can keep things private, answer, not answer. The question is whether you're doing therapy that's a proper technique for. Now, there are some modalities of therapy, like if you're a behavioral therapist, I don't think it matters I don't think that's, now, you could deconstruct the therapy and you could say, well, there are also dynamic issues going on also. But if, the person's conscious sense of the therapy they're doing is they're doing behavioral therapy, I'm going to recondition you to be not afraid of airplanes, and we're going to do fear flying treatment. We're going to do guided imagery. I'm going to put you in a flight simulator. We're going to even get in the car. We're going to drive to the airport. Whatever the things are that you have to do as a behavioral therapist. They do interesting things. I don't know that in that school of therapy, the patient's knowledge of your personal life or not really makes a big difference. I don't think that's real. I don't think that transference and non-disclosure are techniques of behavioral therapy. I don't think that they are. And so I would say, if you're doing that kind of modality, just hold on to your privacy. Don't reveal things that you think are private, but don't worry about it as revealing things that are too private, that's a boundary issue. Using your patient as your confidant, spilling the beans to your patient, that's a boundary issue. Whether you answer or don't answer is a technique issue. It's a clinical technique issue. If you're doing psychodynamic, psychoanalytic technique in your therapy, not answering or delaying your answer and inquiring about the question is a very important technique that you'll learn to do. And whether you answer or not is a secondary thing. The last thing I'm going to say just about this is a clinical advice. It's not related to boundaries, is your exact wording really matters when you do this. If you say, why do you want to know, or why does that matter, it sounds scolding. And it's hard to come up with a phrase that doesn't sound scolding, because you're actually just asking and you might want to know. So I've rehearsed, and this is another, I believe in rehearsing lines, so you have them at your fingertips all the time. So I say, it sounds like that's very important for you to know, and I'm curious what it would mean to you if you found out X or Y or Z, or if you have something else in mind, can you tell me? You want to really not make someone feel bad about their curiosity about you. And if you say, why do you want to know that, it sounds like, I don't want to tell you, and it was inappropriate for you to ask. And you know what? They'll never ask again. That's what will happen. So I think when you do that, you've got to have these are my words. You'll develop words that work for you and your personality and your style, but you've got to have a way of asking that doesn't convey disapproval for the question. And it's a really delicate topic when you do that. That's interesting. I haven't found that, but that makes sense. Yes, you had another comment or question. I don't know. No, I'm not. Okay, so I'm not implying that their question is a boundary issue. First of all, boundaries are your responsibility, not theirs. And clients who have boundary problems, teaching them the boundaries doesn't cure their boundary problems. It might make your conduct in a given session a little bit easier, but they're going to have boundary problems. Their boundary problems are because they can't tolerate emotional discomfort. And they do things, we're going to get to this in a slide about different disorders, but they do things to try to soothe themselves from their emotional discomfort that involve other people. And they're not doing it on purpose. It's unconscious. If I can't stand being submissive, if I feel like a wimpy, defeated man, not a man, if I feel emasculated when I have to submit to authority, then I may lord myself over you in an authoritative way and try to establish a power differential when it's not there. So patients will do that. We absolutely have patients that come in and they quickly have to become the boss and show us who's boss. So now, is that a boundary issue? it's a symptom of a personality problem that needs treatment. To me, your ability to hold the boundaries despite them doing that is what your clinical technique and skill is. But I'm not worried about the threats to the boundaries by the patient. I'm worried about my ability to stick to the boundaries and do the work. I expect patients to challenge the boundaries, especially the more primitive cluster B personality patients. Those are the patients that most flagrantly will stress boundaries. And it's my ability to hold to that will keep the therapy effective. That's how I see it. Sephora? So, right. So the question is about privacy in the social media age, and even beyond that, it's a much less formal, much less private culture in general. So it has absolutely changed what the parameters are for privacy, and it's different in different cultures. So I've never been to India, but I had a supervisor from India, and I learned a lot about India from my supervisor. And he said when he came to America, he was shocked that people will talk about their sex lives in intimate detail, like on daytime television talk shows. But if you ask someone how much they earn for a living, that is a rude question. How dare you ask what my salary is at, whatever clinic you're working for? And that's just like a very different cultural practice here. And in India, people talk about money all the time and won't talk about sex. That's what he informs me. I don't know if that's true, but that's what he informs me. So the dynamics are different, but there are still, it's really my feelings more than the culture. If I feel like that's information I have to keep private. Now, here's an example. For a while, I had an interest in seasonal affective disorder. And so there's a company in Alaska called Alaska Northern Lights, and they manufacture these therapeutic lights. And this was before there were LED lights. So they made these huge fluorescent lights with bulb. They were huge contraptions. So I had a few of them in my office. Now, I don't suffer from depression. I've got plenty of really bad psychological problems. Depression isn't one of them for whatever reason. And so, but my patients saw all these lights in my office, and they would say, that is so great that you don't have shame about your depression, and I really admire that you don't have stigma, and I think it's wonderful that you're doing that. So, I didn't disabuse them of the notion I was depressed. But, so I think if I were depressed and doing that, that would have been good. I think they're right. That wasn't I had to store the lights somewhere, so I had it on my desk, and I wanted to show people, order this lamp or a lamp like this. So I had a model on my desk. But I think there are things that are helpful to disclose. People that work in chemical dependency, almost all of them have been addicted to drugs before, and just working in that field, you're almost, automatically disclosing that you've had problems with addictions before. I think there are things that can be helpful to patients to disclose, but there are things that are too much, and there are things that you're not comfortable with, and there is a line that you're going to draw with privacy. So what can my patients find out? They can find out that I'm married. They can find out I have children. They can find out how much I haven't figured out how to do that, but they can look up on the auditor's website, how much I spent for my house and when. There's all kinds of things you can find out, but they can't find out what makes me mad at my daughter. They can't find out, what I fight with my wife about or don't. They can't find out whether I'm lonely or whether I'm, there are certain things that they can't find out about me. They can learn things about me through information they learn, and they learn things about me through their personal interaction with me, but there's still, a realm of my mind that isn't available to them, whatever they can learn. So I think it's changed where you draw the line, but I think it's still the same basic dynamic. You had a comment. Okay, so I'm going to take advantage of many of the exact words you said in this. So the first thing is there a red line about what you can do? So you can do a lot of bad things, right? So you're asking if there's a red line about what you should do. Okay, so I think that I can imagine therapists sharing that they are divorced, that their parents are divorced. I can imagine therapists wanting to keep that information private. I can imagine different boundaries over different issues for different people. I think people going through a divorce would, by and large, find it extremely disruptive and threatening to have anyone know that they're going through a divorce, and for a while after a divorce. But then I can imagine someone 10 years out from a divorce actually feeling like this is fine, that people know it's like part of my public persona. We have a resident training in our program at UC whose husband completed a suicide, and she was a family physician, and she's switching to psychiatry because her husband committed suicide. But it's like her public identity is, I'm a suicide survivor, that my husband killed himself, and this is what it did to my kids. So her whole like public persona is what it's like when a family member commits suicide, and like and I think it's great actually. Like that is her public identity. So I think that I think there isn't an answer. I mean, there is absolutely a red line that you shouldn't cross because it will disrupt the boundaries. But I don't think it's the same for every person. I think there are people who can disclose certain information and it works for them. And there could be other information that they're very uncomfortable having public that I would be okay with. Look, it used to be a question, should you wear your yarmulke in your therapy room? And that, I do wear my yarmulke. I was considering working at the VA. If I worked at the VA, the Veterans Hospital, I would not have worn my yarmulke at the Veterans Hospital. I think it would be too intrusive on the process. I think it would stir up too much. You're dealing with a lot of paranoid people. And nowadays, people see your yarmulke, they think you're a Muslim. They don't even understand what's Jewish, what's Muslim. So I think there are different settings where certain information is, it feels too sensitive or too much, and other settings where it feels so fine. So I don't know what the answer to that is. I can certainly imagine people being very open about being divorced and it working for their practices. I think it really depends on where people are in the divorce process and whether it works for them to have that shared. And the other thing is people are going to find out you're divorced, whether you tell them or not, because it's a very small world, especially in the Orthodox world. They're going to figure out or find out that you're divorced, and you're going to have to deal with them knowing when you weren't ready for them to know. It's like there are articles written about what to do about pregnancy. Like it was this big chiddush that, oh my God, women are going to be pregnant while they're serving as therapists. It sounds laughable to us now, like it's part of life, but it was a big deal at the time. And it was when women were new to the professional world for therapy when it was being written about. So I think there are all kinds of things that I think it's about what you're comfortable working with. And it's a slippery slope because you're the only one that's, do you know when you're confiding in your patients and using them as like an auxiliary therapist versus no, you're disclosing information because you find it helpful. It's nuanced. So I don't think there's a single answer to your question. Yes. You can give me your advice about the VA. We'll talk later, but that's interesting to know. And you will have to tell me what year you finished your training at the VA, but I won't make you do that in front of a whole room of people. Rifki? Okay, to summarize for the recording, the important point is that Dr. Rivka Youngrice says that my point is very well taken. Liat. Yeah, right. So the comment is about just all the nuances of how much you disclose, what you disclose, and an example. I had a supervisor who, there was a time when I had to leave town. Both of my parents were having surgery in the same day, and I had to leave town, and I had to leave town suddenly. And so he said, what I do is I say, I need to leave town. I have non-life-threatening medical illness in the family, and I need to be with family for it. I think everything's going to be fine, and I'll be back in a week, but I have to be with a relative. It's non-life-threatening medical illness. And that's how he doesn't tell everything. Now, time later, he got diagnosed with a malignancy, and he actually prepared a summary of what his illness was, and he shared it with all of his patients and supervisees. It was an interesting thing. He's a very well-known, well-published analyst, and that's what he is a very high value he places on integrity, and he believes that, and I think I've internalized this attitude from him. I'd never really thought of it till this exchange with you right now, that if you never disclose and you're not honest about why you're not disclosing, then it makes, when you want to know about their question, kind of like an evasion tactic rather than sincere curiosity. It's like a more authentic encounter. It's like, well, look, you know that I answer questions. The reason I don't want to answer this is I really want to know. I mean, I can answer it. I'll answer it eventually, but I want to know what you're imagining and why. And I'll tell you why I think that's important for us to know. It works better. That's what works for me. I'm going to move on a little bit. I think you need to be clear that you're a professional and not a friend. Now, I said something about this earlier. Are you asking whether we'd be friends if we had met socially? When someone says, Dr. Klafter, do you like me? Am I your friend? I had a patient, it's a borderline man. He's a very high-functioning, admirable, brilliant, kind, but really borderline man. His main symptom is anorexia nervosa, but he's a borderline personality structure. If you all met him, you'd love him. I mean, he's a wonderful, wonderful person, but suffers very badly. He's very borderline. And he said, are we friends? Are you my friend? I want to know, are we friends? I said, well, are you asking whether we'd be friends if we had met socially? Or are you asking if the nature of our relationship is that it's a friendship? That's how I kind of answered and turned the question back at the same time. And he was like, oh, I guess I was asking whether you are my friend, but I think you're telling me that you're my therapist, even though we could have been friends if we met differently. And it's true. I think that if I met him socially, I probably would have been his friend. I think I could be his friend. But I can't be his friend or I won't be his therapist anymore. It's not about his nature personally. And that's really a very liberating concept. For some reason, I used to find it very challenging or disruptive, do you like me? Are we friends? Are you attracted to me? Are you all these questions? I just feel so stuck. How am I going to answer that question in some way? But to change it to would you're wondering how would I feel about you had I met you socially rather than professionally? What would have happened in our relationship? That's what you're asking, or that's what you're wondering. I think you're wondering about that. So what do you imagine would have happened? And I don't think that's really an evasion. I think that when they ask me what would happen, they're fantasizing about a different kind of relationship with me, and they feel unable to do that. Like they don't feel like that's allowed to do. I think giving their permission to have that fantasy actually is very liberating and less pressure on me in that way. Yes?
Run through that in the case of attraction, because I don't see it working as well as right now.
You're wondering how I would feel about you or what might have happened between us if we met socially and not professionally.
But in the case of asking about a physical attraction, that's not really, you're not really giving a different answer because the answer is not subjective to the situation in which you met.
I think you are. I mean, it depends on your view. I mean, one of the things is I don't consider attraction that meaningful a phenomenon. I mean, I can feel physically attracted to so many men and so many women. I think and physical attraction is not the same thing as like sexual excitement. And I think that I'm not going to answer directly a question as to whether I find someone attractive because it's too disruptive and doesn't feel safe for someone to know that I find them like physically or personally attractive. But I think that saying, you're wondering what would our relationship be like if we met socially and not professionally, I think that's actually exactly what they're wondering. I don't think that they, like, do you think I'm hot? Like, I don't think that's actually what's going on. I think that they have feelings about me and they don't want to feel like a rejected, lame loser for feeling attracted. They want to know that it's mutual in some way. But I think it really isn't safe to say, like, I find you attractive. I can imagine a scenario where it might be safe, but, like, most of my case, for me, I don't think that would work. I can imagine there are therapists that would work for it, would not work for me. But I think to say, like, well, you're wondering if I imagine... You're wondering, like, what would happen. That's what I think you're wondering about. And that's actually what I believe it is. That's my interpretation of it. If I were evading it, I don't think I would do that. I think that's, well, look, it's for you to judge whether I'm right or whether I'm kidding myself, but that's how I consciously look at it. The fact that I'm your therapist means that we've made an agreement to have a professional relationship and not a social relationship. We made a commitment to keeping this professional when we first met. So that's ultimately why if I have a personal relationship with you, now this is probably only like a borderline or very narcissistic patient that you're going to have this kind of exchange with, because people that are more evolved and less primitive don't really try to force you to state this kind of information. They really don't. They would share it out loud as something they're wondering and not ask you to respond. Someone that like demands that you respond. We're talking about someone who's probably more primitive in an access to cluster B disorder. So, the fact that I'm your therapist means we've made an agreement to have a professional relationship and not a social relationship. That's why I have to say to a young man who's still in my practice, a very, very ill young man, you can never come to my house and meet my family for a meal. Like, that's never going to happen. It's not, whether or not, if you want to talk about whether or not I would enjoy you there, or whether I think you'd like my family or they'd like you, or what I think would happen, we can imagine that together. We can have that discussion and imagine that together. But the fact is it won't happen regardless of what we imagine. It's not a question as to whether I think you'd like them or they'd like you, or whether I trust you, or whether I trust you around my daughters, or all the things he's imagining. It's never going to happen because we made a commitment to only have a professional relationship. And then he's freer to imagine whether I would like him socially, because he knows it's not going to happen either way. It actually makes it safer to wonder about it. Yes?
How would you apply that principle that you said to a borderline client who I have said that to, left, 3 weeks later, can we still remain friendly
Well, I think I would say, listen, this is not something I can answer over text, and you'd have to come in for a session and pay me for the session. I think you're talking about, very briefly, I think you're talking about continuing a professional therapeutic relationship, and I have to be compensated for my time, and I think you would need more from me than a text once in a while. I don't think that's, you have to come in and talk about it with me. That's what I think I'd say. I'd probably indicate no, but why don't you come in and talk about why? I think that's what I would do. Yes. So the question is about children that ask, really personal information. So again, it's a question of therapy technique. Children are naive. They don't understand what your role is as a therapist. I think that I think therapists do it differently, and I'm not working as a child therapist, but I have done some work with children during my training. But I think that you develop a way of turning their question into something that's an imagination game that you play with. I think that's the most common thing that's done, is I say, well, we have special rules here. We have special rules we play by. The rules are that there are certain questions that when you ask, I want you to tell me what you imagine the answer is, and I'm not going to answer myself. I think that's what some people do. Other people, I think they just kind of answer. That's sort of like beyond what children can handle, and what you do is you just don't answer what you don't want to answer, and you say, like, well, that's private information. I don't tell people my address where I live. You're going to meet with me here at this office, but I don't tell people where my house is. I think those are the two ways that I've seen people that just very clearly, I'll answer this, I want to answer that, or some people try to turn it into an imaginative play. That's what I think people do with children. But it really requires consultation. What used to be called supervision, we now call consultation. It really requires, if you're having that issue with children asking you questions, I think you need a consultant to go over what some of the techniques are to do that. And I'm really not, I wouldn't consult with someone who treats kids. I don't have the expertise with children. Starting 12 and up, I can do. But below 12, they communicate through play much more than language, and so it's just not my skills that I've mastered. Hugs, gifts, and clients that won't leave. Okay. So, when patients say to me, okay, let's say patients hug you and they don't ask. Well, there's no question. They hugged you already. What are you going to do? Okay, they hugged you. That's happened. I've been ambushed, hugged by patients. There's not really a question to ask because it happened. The next time I get up, I might be kind of like in the Heisman maneuver when someone ambush hugs me. I'm not a hugger with clients. So I found myself once saying something. Someone said, can I hug you? And I said, I looked sort of uncomfortable. I said, I think we're not going to hug, but why don't you tell me about your feelings about wanting to hug me right now? Like, what's happening with you right now? That's what I think I said. And now I sort of answer that way, like it sort of worked. I say, I think we're not going to hug, but what makes you want to hug me right now? Now, I will do that even with men. I really don't think it's appropriate for me to hug female patients for purely therapeutic reasons. I'm not talking about Shmiras Negia. I'm not talking about halacha now. I think it's an unsafe physical contact. I think therapy is very much about expressing uncomfortable emotions with words, savoring the feelings, talking about them openly and directly. And when they're put into action, that's actually like a more primitive way of coping with emotion. So I think hugging is usually a way to ward off or neutralize some kind of like uncomfortable feeling. That's what most actions are. So I don't want to hug anyone or be hugged. And I think that it's an example of when I want the patient to talk about what they're feeling rather than hug me. So you have to set up a frame where that's what we do. I mean, this is like the drill here. We talk about things that other people don't pay attention to in the rest of their lives. Like therapy is weird. We talk about things. Yes?
It's been my experience that those types of things tend to happen 1 minute after the session is over. And so to sit down and say, well, let's talk about what this means to you. We need a yes or no now because the next person's waiting, that kind of thing. Scheduling is an issue.
Right, so there's a general term for what are called doorknob comments. These are doorknob interventions. The session is not over. If someone is trying to hug you 1 minute after the session is not over. The session is still alive and well. You might think it's over, but this is part of the session. The session starts when the patient arrives to my waiting room. The session ends when the patient gets in the car. Maybe it's over when the patient gets in the car. So the session is still going on. The patient thinks that they have it's like one of my therapists called it a hit and run. It's like they think they can get a zinger in and then they won't be responsible for it in some way. But your job is to bring behavior that's they think is under the radar back onto the radar. That's your job. So your job is to try to find a way to make that able to talk about. So you'll say, look, I'm not going to hug you. We have to stop now. We can talk about this at the next appointment. And it's tough. When people say stuff on the way out, it's very hard to deal with it in an elegant way. But you can say, you're really sneaky. You try to get stuff in when we don't have time to talk about it anymore.
I want to challenge that because I think that does happen, but it also doesn't always happen. In other words, not every request for a hug or giving of a gift is a sneaky way to get in another in. And maybe I'm not dynamic enough, but I think sometimes it's earned. It was they got something in that session that was just overwhelmingly satisfying.
No, I'll repeat his question after.
Satisfying and emotional, and that's their expression. Now, granted, that's something to be processed, but I don't necessarily subscribe to the notion that is inherently.
Okay, so all right. So the comment is number one. Maybe I'm not dynamic enough. Just have to repeat that part of it. But then that not every hug or gift is sneaky or and it may be or a roundabout way. It may be like a sincere, authentic expression of a feeling. But what I was saying is sneaky if someone tries to do something at the very end of the session when there's not time to talk about it. So I'm suggesting sneaky, some word to indicate that they're doing something that you don't have time or the ability to respond to now as a therapist. It would be like you're out at a supermarket and the patient says something to you and they want an answer, and it's like you can't do this right now. It's like you don't have the time or the footing anymore. Like it's a boundary issue, actually, in a lot of ways. They're trying to get you to do something that you may not do in the same way if it was in the middle of the session. That's what I mean by sneaky. But the second thing that's more important is, no, every hug, by definition, is an expression of emotion that the person is not able to express with words, or else they wouldn't be hugged. That's what action is. Action is when words fail. And a lot of our patients are having a lot of trouble being verbal, and they're more primitive in doing things in action. And so, no, it's not that it's like inauthentic or not inherently sincere. I think that neurosis and conflicts are sincere. But I think that this is someone who needs to be able to relate to you in an intimate way without concretizing it in physical touch or physical affection. And by the way, this is not about sexual boundary violations, but that's also very true of sexuality. There are many people that regress into sexual behaviors that are unable to express their needs or actualize their needs interpersonally with like non-sexual behavior. Like there are many things that happen where people, they lack the skills, capacity, maturity, impulse control, containment, reflectivity. They can't do these things verbally. They regress to behavior. Violence is that way. Lots of things are a regression when people can't handle the emotion. And that's a lot of what you're trying to do as a therapist, is help people be able to sit with, uncomfortable emotions. It's like the famous play on words. The expression is, don't just sit there, do something. But we say to therapists, don't just do something, sit there. Because it's harder to just sit there than do something. So that's what we're trying to help our patients do to a large degree. I think I have another... So in the last 5 minutes, how does therapy work? That's not what we're going to try to accomplish. So, but I think that, yeah? About not hugging? Okay, so for the recording, Sylvan is saying that if you find yourself ambush hugged, then document that patient hugged me, explained why we do not hug in therapy, did not initiate hug, was unable to prevent it, and document that in your note. That's fine, and agrees otherwise with me not hugging and not agreeing to hug. That I will not even dignify for the recording. We don't want anyone to ever hear what you just said. So, okay. So it's important to be very clear about how therapy works for boundaries. Now, what do I mean? I'm going to give you just a very quick thing. So a psychoanalytic model for how therapy works is the patient is inhibited by emotional conflicts. What does that mean? Uncomfortable emotions are intolerable for the client. The patient is unaware of what the uncomfortable emotions are. They remain unconscious for that reason. Skills and goals in life that require the patient directly to confront or work with uncomfortable emotions are very inhibited. So therapy is the process of helping, I should say, patients and not therapists. And yes, it's probably a Freudian slip, but we don't have time to analyze it. Therapy is the process of helping patients directly experience, savor, work through, neutralize, and detoxify uncomfortable emotions. So let me give examples. Avoidant personality and dependent personality. These are people who have major problems with assertiveness, aggression, and anger. They are very afraid of their assertiveness and their aggression and their anger, dependent and avoidant patients. People with obsessive-compulsive personality, they cannot tolerate their passion, their emotion, spontaneity, lack of certainty. They find this very, very uncomfortable. Histrionic patients, they can't tolerate being ignored. They can't tolerate feeling unimportant. They can't tolerate feeling peripheral. Narcissistic patients, they can't tolerate injuries to their self-esteem, failure, rejection. Borderline patients, they can't tolerate aloneness, separateness, or rejection. When these patients challenge the boundaries, what they're doing is they're trying to neutralize these uncomfortable feelings. That's what's going on in the therapy. And your job as a therapist is to help make those uncomfortable feelings more tolerable. So by asserting the boundaries and not giving in to the pressure to change your boundaries, you're helping them actually confront these unpleasant emotions. That's why keeping the boundaries firm is very therapeutic. Because if a patient demands a hug, like this patient who really wants to express a hug, or before going away on vacation wants to hug you, okay? Why does the patient that patient needs help with tolerating some uncomfortable emotion before a separation, and hugging them will not help them with that. You could take them home, move them into your house, tuck them into bed every night, cook them breakfast every morning. Sylvan advises against it as an attorney, but you could do that, and it's still not going to be enough attention. It actually isn't going to be enough attention. There is not enough attention you can give to satisfy this. That's not how therapy works. You can't reparent someone. You cannot fill up the hole that was there. You can help them repair the hole. You can help them repair the structure, but you cannot fill up a leaky boat. You can't pump the water out of a leaky boat. It's not going to work that way. So by adhering to the boundaries, that's how you are helping patients confront their painful emotions, and that's how psychodynamic psychotherapy works. Now, what I'm saying is true of all the other therapies too. If you have a cognitive model, a behavioral model, an IFS model, an interpersonal model, an ACT model, whatever the model is, when people are trying to change the boundaries, it's because they can't tolerate some feelings that they need help with in the therapy. And holding to your boundaries, it's like holding their feet to the fire to work with the issue that's really giving them trouble. And that's why it is sincere when a patient wants you to do something different, when they want to give you a gift, when they want to hug you. Of course it's sincere. It's very real. It's coming from a very primitive place in the patient. That doesn't make it healthy or healthful or therapeutic to indulge. It's therapeutic to not gratify that wish and hold their feet to the fire and work through the uncomfortable emotion. That's why being very clear about how your therapy process works helps you understand how keeping the boundaries intact fits with your therapeutic model. Yes, Rifki. Rifki Youngrice agrees again. Yeah. For the record. It's inadequate. Okay, so the idea sometimes a cigar is just a cigar, so sometimes a physical embrace, an expression of spontaneous emotion is just a physical embrace and an expression of spontaneous emotion. I mean, a hug is meaningful. That's why the person wants to hug you. Now, whether you want to avoid the hug in the final session I understand that may be very common, but I think the same principle applies. I also do think, Sylvan can, not now, but after, when we're standing around and saying hello, he can tell us whether it's different for a woman to hug a woman than for a man to hug a woman legally. I imagine that it is, but I think there is a difference. I do not think I would let my female patients, I would not let my patients hug me goodbye at the end of therapy. I don't think I would. I mean, it just feels like it's not what I do as a therapist. It was just one time, and it just happened. But this is not how we think as therapists. Nothing just happens. I mean, there's... Well, look, patients, first of all, what I'm talking about is your internal processing of something. What you say out loud to a patient depends on the therapy, on the patient, on where you are in therapy. And the fact that the patient does something in the last session that you can't really analyze because it's the last session doesn't make it less meaningful. You know, it's practically true that therapy is over, so you can't analyze it anymore. But that doesn't make that like somehow a different hug than a hug in the middle of a session. And you know, I don't. Look, I think gifts at the end of a therapy are common also, but it is a big deal. I heard a long, detailed analytic case where the analyst declined a gift at the very end of therapy, and they talked about it for months. The termination was over whether she's going to give him a gift or not, and then she didn't give him a gift. He stayed neutral about it, and she didn't give him a gift, and she realized that she had a tremendous fear that she's not meaningful to him. He's going to forget her, and the gift is a keepsake. That's probably true of all gifts. That's why we give gifts to people. We have like an artifact of ourselves in their lives or in their home. That's why we give gifts. And so she realized that was what her fear was, and as she analyzed that fear, it felt inappropriate of her to do this. That, you know, she was real, she was part of his life, she was in his mind. He would have memory. They had the meaningful relationship for what it was in this long analytic treatment, and then she left and departed. And I respect that. I think that's excellent work, actually. The fact that not all of us are doing work at that level, it's something to aspire to, not to say, it's just a gift or just a hug. That's my thought about it. So I think, are we beyond the time? Oh, 5:40. Okay, good. So we can boundaries as technique. Patients' emotional, so this is what I was starting to say, patients' emotional conflicts are what drive their challenge to the boundaries. Like narcissistic patients, they crave validation and admiration from the therapist. So what do people do? They want to know your opinion of their clothing, or they want to know what you think of their essay that they wrote, or they want to know what they really want to know, they demand that you give them an evaluation of some kind. Or wealthy clients, that should say they buy special privileges. I think that there are absolutely different issues dealing with the uber wealthy. They cancel a lot of sessions. They seem to have very good insurance, which is also remarkable. They have very good insurance that will pay for almost everything out of network, which is a remarkable thing. Narcissistic patients may demean the therapist when self-esteem is injured during the therapy. They need empathy and insight into their vulnerability. They don't need validation. Okay? There's a big difference between validation and empathy. Empathy is my accurate ability to participate in your actual emotional experience subjectively in real time. That's what empathy is. Validation is when I reassure you that the narrative that you're most comfortable with is true and valid. It's a very different. Validation feels good in the moment, but it doesn't encourage change. Validation actually keeps people from stressing themselves. Now, there are exceptions in patients like with incredibly shattered self-esteem who don't trust their emotions. So we sometimes use the word validation, but we're talking about something else. When we say those patients need validation, they don't need validation. They need to be encouraged to follow their instincts. And we only validate them in the sense that, no, what you're feeling or reacting to really is something very important. But that's not what I'm talking about with narcissistic patients. Narcissistic patients want to be validated because they don't want to be in touch with these really crummy feelings of being shattered or worthless or insignificant or ineffective or unlovable. They don't want to be in touch with those. When someone else has rejected them for a job or reprimanded them at work, they want to feel that that person is a terrible jerk. That would be very validating. Isn't my boss such a horrible, horrible jerk? Tell me, you agree with me that my boss is a jerk, don't you? Don't you agree that, how can you believe my boss said that to me? You know, those are difficult moments in the therapy, but they are not going to benefit from validation. There's probably a very good reason that the boss, now you're not going to accomplish this in one session, but over the course of the therapy, it's not a therapy of validation. You can empathize, well, it sounds like you really feel terribly insulted by your boss's feedback. That's more empathic than validating. Yes, your boss is a jerk and what you did is fine, and that boss is terrible. That boss is jealous of how smart you are. You're right. That's validating. It's not therapeutic. It's really it's not helping anything. It helps the person in the moment deal with his or her distress. But it's the same bad path that the narcissistic patient is going down in trying to get relief from this distress. Like, that's not a helpful path. That is narcissistic personality disorder. That's grandiosity. That's not a helpful method. Borderline patients, they demand constant intersubjective understanding and connection. They cannot tolerate distress. They try to manipulate or coerce the therapist into gratifying these needs and reassuring their distress. The challenge to the boundaries is from the borderline psychopathology. Their inability to handle possible disconnection or loss or distress is why they're threatening the boundaries. You have to see the boundary threats as symptomatic of the personality problem. Histrionic patients, they want to feel special to the therapist, the favorite patient. They try to learn info about other clients. They're competitive with other clients. They become personally seductive often to the therapist. That's how they're tolerating with the distress of feeling like just another sibling in the family or just another person or not special to you. They need to be your favorite, best patient. And the things that they do to the boundaries are serving that need. So the threats to the boundaries, the pressure to the boundaries are symptomatic of the underlying problems. That's how to see them. It's to see it as a symptom of the personality psychopathology. A little bit about enmeshment. So the definition of enmeshment is it's when emotional boundaries are unclear or permanently fluid. It's when people take responsibility for another person's feeling, state, behavior, or thinking. We expect another person to be responsible for ours when that happens. We expect that others will comply with or gratify our needs and wishes. This is what enmeshment is like. It's the opposite of autonomy. It's the opposite of individuation. Right? Enmeshment is counter-autonomous and counter-individuated. It poses a challenge to interpersonal responsibility, to personal responsibility. There are cultural factors in certain communities of like having collectivism or individuality. So a lot of our Orthodox communities are very collectivistic. I read your mind. Yes. Okay, so this is what I was saying before. The positive perspective is like everyone you know is a member of your family. The negative is like everyone you know is a member of your family. Okay, so Orthodox communities are very family-centered, and they have collectivist values compared to the surrounding culture in America right now. Now, I don't think that's the same necessarily in China or Japan, where there is a more collectivist ethos. We're also very community-centered. I mean, we make major sacrifices for the good of the community. We see ourselves as part of the community. Our, sense of self is very tied up to where we are in a family, where we are in a yichus, where we are in a community. Identity in a lot of Orthodox circles is almost synonymous with like, what's your uniform? What's your hashkafa? Which yeshiva are you aligned with? Who's your rebbe? Which musar do you follow? It's almost like in America now, like what political party are you a member of in Orthodox communities now? Shidduchim. People are married before they're mature and autonomous. People in our communities get married when they're still children. I'm supporting a married child right now. I mean, I know what this is like. And we do that. I'm not criticizing, I'm just observing that we are married before we are mature people or individuated. And now, if the parents make the match, So the parents are responsible for the match and not the person himself. Let's think about what that actually means. I can't think of a more important decision in your life than who you marry. I don't think there's a more important decision than who your spouse is. That means that your marital that means that, someone else is making the most important decision of your life. And that's a normative in our communities. That's part of our enmeshment in our communities. Thank you for embodying this slide for me. You could look at it that way. That's a great comment. You could look at it that the most important decision is who your child's going to marry. Many people are not self-sufficient economically in our communities for their entire lives. That's actually normative. That's also an instance of enmeshment. So, do any of you know who Dr. Vivian Skolnick is? Yes. So Vivian Skolnick is one of my great heroes. She was a very active member of Nefesh, and I think founded Nefesh Chicago. And she was personally, for a lot of my career, very supportive, like a surrogate mommy for me, speaking of my enmeshment. And so she said about Orthodox communities, regression is idealized, dependency is rewarded, autonomy is punished as rebelliousness, and maturation is discouraged. That's what she said about, she didn't pull any punches, Vivian Skolnick. Responsibility for individual choices is subjugated to parents, halacha, spiritual leaders, and Das Torah. This is part of our value system. I mean, I'm giving these are wonderful values that I'm part of, but there are consequences for adult, autonomous, individuated maturation that are cultural factors that are real in our communities. So, in terms of protecting boundaries in working in the Orthodox world, I think you need to understand that the exaggerated enmeshment is culturally normal. You have to see how it's a symptom of the psychological problems that the patient needs help with. And you have to see that it's really not about you. It's a form of transference. When patients get very enmeshed with you and they demand you to take care of their emotional needs, that's what they do with everyone. That's what they do with their parents. That's what they do with their siblings. And they're doing that with you. That's what transference means. Transference is when I act out my emotional problems that I have in my entire life. I now act them out with you in the therapy. So that's how you have to see the enmeshment with you as a clinician. You need to scrutinize your frame and boundaries. You really do with enmeshed patients. Not in a self-punitive way. Not like I have boundary problems and oh my gosh, I did this, I have boundary problems. We all deviate from the frame all the time. We do all the time. But when you have a patient that's really challenging the boundaries and overtaking your life, like all the people that we all spoke about that we shared today, I mean, those are the people that you've described in giving your vignettes are patients that really challenge your boundaries. It's a therapy technique. It's not that you have a boundary problem. It's not like, oh, I regret that I don't have such firm boundaries. No. You have a very enmeshed patient right now. Use this technique with this patient. You don't have to scrutinize your boundaries with patients that are not enmeshed. The patients observe your boundaries. It's not really a therapeutic issue with a lot of other patients. But with these patients, you have to be really, really clear about your boundaries. You need to present these cases to consultants that used to be called supervisors. Why do I distinguish? To me, a supervisor is someone that you're subordinate to, and they have responsibility for your work. So if you work in a clinic, the director is your supervisor, and they have authority over your work. If you hire someone to review a case, that's a consultant. They're not supervising you. It's an antiquated term. We stopped using it in Cincinnati. So you need consultation, what we used to call supervision. You cannot sort this out on your own. It's like trying to get therapy by doing self-therapy and not go see a therapist. I mean, it's just you need to get consultation and supervision from someone whose judgment you trust, and also someone you feel you trust as safe that you can present your work to, including your rough spots that you're not comfortable with. You've got to go to someone that you feel is not going to judge you. That's really how to do this. You need to be clear in your mind about how the therapy you provide works. and how deviating from the frame interferes with your ability to do that. You have to really know that very clearly. And that makes your adherence to the boundaries meaningful and not just a ritual or a rule. It's a meaningful thing when you can do that. When the patients want you to cross your boundaries, share your observations out loud and consider, like wonder with them why they're pressuring you to do this. You know, so you're asking me to lower my fee, and that is how you'll know that I really care about you and I don't just care about money? Is that what you're saying? So if I need to keep my fee up, that means I don't care about you? Is it a test? You know, say it out loud. Clarify with them what they're saying. You want me to tell you whether I'm happily married or not? Can you tell me how knowing this information would be helpful to you in some way? It sounds like it feels important for you to know this. You know, you really want to know whether I'm happily married. That, say out loud how they're challenging the boundaries and wonder why they want you to do that. And I think you'll be able to figure out with them how that would, in the moment, soothe them from some sort of difficult emotion that they can't tolerate, because ultimately that's what the therapy is about. The therapy is about giving them greater capacity to tolerate uncomfortable emotions so they can actually live their lives in the way they want to. It's about expanding emotional freedom. People that are trapped with uncomfortable emotions, you know, they lack freedom to live their lives the way they want to. So they're prisoners to their uncomfortable emotions. So the boundaries, when they try to press the boundaries, that's like the in-person, in vivo activation of this problem. And if you hold firm, you're sort of pushing that right back into their face and making them confront what they're afraid to confront. So it's hard to do because it increases their distress, or it doesn't soothe their distress. They want you to soothe their distress by changing the boundaries, by messing the boundaries, and by holding to that. It's painful in the moment, but they will respect it in the long run. They will respect it as an act. It's really an act of love in a lot of ways. It's the best therapy you can provide. So if you believe that, you will do it and you won't feel guilty about it. We have to assert boundaries with communal leaders. It's hard to do. Rabbi X is a communal leader. He calls you on the phone and he says, or he calls me on the phone rather, and he says, Dr. Klafter, can I tell you something confidentially? What's the right answer to that? I don't know what the call's about. I have no idea. Can I tell you something confidentially? What's the correct answer? Yeah, I think the correct answer is no, you can't. No, you can't tell me something confidentially. Now, you don't say it like that. You probably say, Rabbi, I don't know what it is that you want to talk about with me, but I want to clarify before you say anything. You're not my client. We don't have a confidentiality arrangement. I don't know what this is about. This is not a confidential privileged phone call. You have to do that. It's hard to do to rabbinic and communal leaders. They have a lot of power. They have a lot of authority. You cannot agree to give someone a confidentiality agreement who's not your client. Nothing is confidential unless you decide it's confidential. No one has the right to your confidential consultations or services unless they're paying you. Do not tell anyone, that you're going to keep something secret unless they're in that arrangement with you. And you may be duty-bound to disclose what they tell you. The fact that you've said, it's like I promise not to, but you're not their therapist. It's not a confidential arrangement. So don't get into arrangements with people that are not your patients as though you're a professional. You're not in your professional role. Don't pretend you are. It's a big mess that we get ourselves into, making promises to askanim, rabbanim. Don't do it. Clarify, no, you'd have to come in and pay for my services, and then I can do it. Don't give professional advice to people who are not your patient. Don't do it. If you want to answer, you want to speak at an event, you can give general information, but be careful you're not giving anyone specific advice about their client. Be very careful to not do that. It sounds silly, just never answer your phone. Don't answer your damn phone. Why do you need to answer your phone? It's just, you're going to regret it. Don't answer your phone. You have voicemail, so you don't have to answer the damn phone. Everything you ever said to someone you wish you didn't, it's because you answered your phone. Don't answer your phone, okay? Just never do it. Turn the ringer off. There's no reason to ever answer your phone. you will have nothing but trouble from it. There's no reason to ever answer your phone. Never do it. Listen to your messages, and call back when you've thought about what you want to say. And you know what? You won't want to call certain people back. There's a Rav calling me over and over and over again, and I will never answer the call from him. I don't block the call because I want to see how many times he calls me. He knows I treated someone, and he wants to get information about it, and I'm not going to talk to him about it. Why should I? You need your own therapy. You're very vulnerable to rabbis, askanim, and other communal leaders. I am too. I'm not speaking from a position of authority here. I'm sharing. You all need therapy. Like I think I say, get consultation. You need it really, really badly. The same as you need therapy badly. You really need it very, very badly. You need consultation very, very badly. Like it's very, very serious. You need it. You need it. It's not a sign that you have a weakness or a vulnerability or a problem. It's part of professional development. And without that help, I don't think people can really hold themselves in a good position against authority figures in our communities. Okay, when you call the person, don't answer the phone under any circumstances. When you call the person back, every phone call starts with this: I have 10 minutes to talk to you. Okay? I have 15. First of all, you shouldn't talk to anyone more than 15 minutes. That's too long. But that's probably my limit. But there is a time limit at the beginning of the phone call, and you've told them at the beginning, and the phone call is going to come to an end after 10 minutes. Every person you talk to is a professional. Kibitzing with your friend, no, you can talk all night long. I don't care about that. I'm talking about when you're a therapist, talking to a client, talking to a client's mother, talking to a rabbi. And if it goes on longer than that, they have to come in and pay you for your time. So at the beginning of the phone call, make up a time limit and tell them I have X amount of minutes for the phone. A very important technique to do. Will save you a lot of headaches. Have rehearsed lines. I understand that you're trying to help, but anything you tell me about Yankel, I'm going to repeat to him, including this phone call. Have that at your fingertips. No one is allowed to call you and give you information that you're not allowed to tell the patient. Now, if it's really your judgment that it would be disruptive and not helpful for them to know, and it's a stupid phone call anyway that you're not going to pay attention to, okay, that's your clinical discretion, but that's your clinical discretion. That's not an agreement with the person calling you on the phone, which is, again, why it's good to just not answer your phone. Don't be available. Don't make yourself available to people unless you want to talk to them. If possible, avoid working in the religious community for the first 5 years of practice. Okay, it's probably too late for you. Now, why do I say that? Because we learn really weird, bad habits when your first clients are brought in by askanim and rabbanim and meddling families, and they're your neighbors, and they know your cousin, and they went to the same yeshiva or seminary. It's very hard when you're getting your professional grounding. I think it takes about 10 years to become a professional out of graduation. Like you're like becoming a professional still after you graduate. It's like a 10-year process to becoming like a confident, seasoned therapist. The growth continues after that, I hope. But you're after 10 years of working, a reasonable number of hours, you are pretty seasoned professional. You won't be able to handle it. It's too crazy. So the first 5 years, if you can work not with Orthodox Jews, or at least not in your own community where you're a stranger to these people, it's much easier to focus on the bread and butter therapeutic skills. And then when you've got a lot of experience under your belt, you can manage the pressure because you've developed the skills. But it's very hard to learn those skills. So I'm just saying we got to stop now. It's very hard to learn those skills while you're under all that pressure. And we'll skip this for now.